leave last year. I was signed off sick with severe anxiety and depression. This is not the first time I've had these symptoms or been signed off, but it's certainly the most severe. Work appears to be a major contributing factor, and I've been put off for a month, and I've been put off. I was struggling, I was struggling to manage work and being the parent wife I want to be. I think that is a kind of this notion of being pulled in different directions, and often as doctors having high expectations for both those roles. I'm a paediatric reg, currently on mat leave. I was quite happy to go back to work and was looking forward to it, but last year my best friend, who was also in paediatrics, took her own life, in part due to anxiety and panic at work. It was understandably shocking and tragic, and it's really affected my feelings about a further career in medicine. I've been seeing a bereavement counsellor, but feel that someone more qualified in the realities of NHS paediatric registrar life may be able to help me work out what's best. I have a few more months to decide, as that's when I'm due to go back. So you could say, Houston, we have a problem, or maybe Matt Hancock, that's a rather strange along, we have a problem. And I think that we can get a sense of what this problem is. This isn't actually PEDS, this is called Meds trainees, but it's a very good survey. And there are all things that occur, certainly with PEDS. And I should perhaps add that I'm doing a study for the Royal College of Paediatrics and the RCPCH at the moment, looking at their concerns about retention and career pathways. And I've just been together with a colleague looking at some maybe data that you filled out, a survey that was done recently, and there were some open-ended answers, and very similar themes are coming through. So 80% felt that work sometimes or often caused them excessive stress. Nearly 20% had to carry out a clinical task for which had not been adequately trained. Obviously, that is going to be more apparent during that issue during COVID. Quarter felt the work had a serious impact on their mental health, and nearly 50% felt that this poor morale amongst the team had a serious or extremely serious impact on patient safety. And I think when we look in the press and there's concern about the impact of COVID on the mental health of the medical workforce, we absolutely need to remind ourselves that this is not a new problem, this is an old problem. And in the book, I had the kind of notion that there's a gap, and what the gap is really there's a gap in, I called it a psycholectomy, which is my own term, but there's a gap in our real understanding of the psychological demands of medical work. And I am not alone in saying that, and neither am I original. I'm certainly not the first person to say that. And Simon Sinclair, who wrote this book, Making Doctors, it's quite old now, and tragically he was a psychiatry consultant and he died very young. He had this common: medicine, unlike the military, is not scientifically interested in its recruits' psychological experiences, either their individual morale or the esprit de corps of their groups. And I think it's interesting that it's now, under the time of COVID, that actually, let's say, Neil Greenberg's work on moral injury, that the parallel is being made with the military. And I think that the military as a parallel for medical work is a much better parallel than the occupational parallel that is often made, which is with the aviation. I think aviation we can learn, and indeed have learned, on the human factors approach to safety and avoiding error in the operating context. But in terms of the psychological impact of the work, I don't think that aviation is the right parallel, and military is a better parallel. And interestingly, yesterday I was asked to talk to a group of sports psychologists who coach elite athletes. And I think that they're also very interesting parallels with elite athletes who feel they have to push themselves, who feel that their family are invested in their careers, who, I think they're in, and whose identity is so bound up with it. and I think there are interesting parallels that could be drawn there. Anyway, this one of the notions that I have explored in the book and I talk about a lot is this notion that we're not giving adequate attention to the real psychological demands of medical work. So, Nisha, I have to ask, because in Teams I can't see the chat, but maybe in chat you can just write some of the reasons why you decided to train as a doctor. Just put it into the chat, and Nisha, maybe you can read them back. Is that okay?
Yeah, no problem. I can man that. So everyone type it in. It should be available.
And yeah, some of the reasons. You don't need to write the most perfect, but just some of the reasons.
We've got to make a difference.
Yeah.
To be helpful to others.
Yeah.
I put I love working with children.
You put, sorry, what?
I put I love working with children.
Yeah.
Wanted to help people. I liked science and people and an academic challenge, and I wasn't aware of alternatives. To relieve distress.
So lots of around helping people, about academic challenge, about making a difference with PEDS. I mean, it's interesting you should say about PEDS liking children. I have, you know, I have encountered some paediatricians, one paediatrician who really didn't like children, but she'd chosen PEDS because PEDS were much more, it was a much friendlier department. And she really didn't get on very well with children, and she certainly didn't get on with patients, with their parents. So it's sometimes one can, you know, one's, and I'll come on to this, one's career thinking can be skewed. Any other, Nisha, any other kind of interesting things that have gone into the chat?
Yeah, we've got to avoid an office job.
Yeah.
You have to agree there. Wanted a career that was useful, helpful, and important. Paying it forward and help others, children's and young adults with transition, also from my lived experience.
Yeah. Okay, so lots of different reasons why people can choose the profession. And it's interesting that somebody said that they didn't really know of alternatives, and when I come across, and these are rare, but obviously I see a particular section of the medical workforce. I also think, and people sometimes challenging me, I absolutely accept I don't see a random selection of the medical workforce, but equally I don't see outliers either, because if you look at that survey from the Royal College of Peds, if you look at from the Royal College of Physicians, the stuff that's going on I'm doing for the Royal College of Peds, these problems are not outliers. They are they're common and they're embedded, but it's relatively rare for, you know, for it not to work out for you at all. But one of the things that I think is very sad is that it's from school onwards, at critical stages, at choosing A levels, choosing a career, alternatives aren't sort of really laid out to people, because medicine is something that everybody knows about, because everybody will have had encounter with the doctor, and there are all those, you know, TV programs, Casualty, ER, you know, Holby City, whatever. Whereas some of the things that I've seen people who want to make a difference, you can't, there's not much drama necessarily in a research lab, but God knows those people who've got that vaccine, who may never have had an individual patient, but working in AstraZeneca or Pfizer or whatever, they will have saved more lives than you guys will ever do in your life. But research, things around medical physics, all sorts of other careers are never they're never laid out to people. And some of those non-patient, working within healthcare, but non-patient facing options would have been better for some of the people I see, but they're never really explored. So if we start with the positive, and it's always a good idea to start with the positive, when you're going through a really good phase at work, what exactly might you be feeling? Again, in the chat, just think back. It could be yesterday. It could, you know, it could be really, it could be very recent, or it could be further back, but something, a day when you're having a really good day at work, the sort of day you go home and you say, if you live with a partner or flatmates or whatever, said, you know, a really good day today. What are some of the words that come to mind when you think about a really good day at work? And put that into the chat. It's so disconcerting talking to myself. I have no idea if anybody's doing that, but I hope they are. Any words in the chat, Nisha? Hello?
Nisha, you're muted.
This is the problem with Teams, because if when you're looking at your slides, you can't look at the. Okay, so just Nisha or somebody, what are some of the things people are writing about good days at work?
Nisha, we can't hear you, so I'll just read some out, okay?
Cheers, thank you, whoever you are.
So
Thanks.
it's Roland here, sorry. So learning new skills, positive energy, feels like that they've really made a difference to a family and a patient. The whole team working together. There's loads coming in, it's great. Feeling on a high. You're in the right place at the right time, and it's just meant to be. You're meant to be here. Making a difference, learning new skills. I'm going backwards. Appreciated and useful. Good teamwork again.
Okay.
A parent or colleague said thank you.
Okay.
So I'm not getting everyone's in, but it's great.
Okay. So we hear a lot about burnout, but burnout is a continuum. We don't hear a lot about what's on the other side of the scale, the positive. And what is on the other side of the scale is occupational, what I would call as a psychologist, occupational engagement. And it's really lovely with even with a small sample that comes out. So the three things: a sense of energy, personal involvement, with, you know, knowing that you're making a difference, and a sense of efficacy. And although other things came out as well, those three themes certainly came out of the words that you've just quite, you know, randomly given me. But then if we flip the coin over, if you were going through a difficult phase at work, what exactly might you be feeling? And now write down some words or phrases that come to mind with that.
I think Nisha's still on mute, so I'll have a look.
Oh,
okay.
You're back. Yeah. Keep going.
So the messages we've got so far, we've got overwhelmed, out of my depth, not in control, worried you've missed something, definitely felt that, unsupported, too many patients feeling overstretched, not giving the standard of care we should,
Yeah.
Underappreciated, absolutely, worried about decision making.
Okay. So then we get to burnout. So burnout, some of the things about burnout, it relates to work, it's occupational burnout, and Christina Maslach, Dutch originally, but then in California, defines it as three distinct feelings: emotional exhaustion, it's just all too much; depersonalization, you don't see the patient in front of you as a person, it's just, you're using your empathy, and you just don't feel you're not doing a good enough job. I think some of the anxiety things that come maybe as secondary to that have also been mentioned, but I think some of the words that you've given me, and you can probably relate to that. Now, why does it matter? Tate Shanafelt is an oncologist also at Stanford. He was previously at the Mayo Clinic, and he's done some of the best work on burnout. And he talks about the effect of physician burnout on broken relationships, alcohol, substance misuse, depression, and sadly even suicide. That's the personal impact, but then also their professional impacts. Burnout relates to a decreased quality of care and increased errors. If physician burnout relates to decreased patient satisfaction, you start to put in less work, and it leads to greater physician turnover. So one of the things that Schoenfeld is arguing is, and there are a number of people who are arguing this, is that it looking at the economic as well as looking at the psychological and the clinical outcome cost, there's also the economic cost, and he's saying that not paying attention to it doesn't make sense morally, in terms of you don't want this happening on the left side hand side to your hardworking doctors, but it doesn't make sense in terms of clinical safety and clinical effectiveness, and it doesn't make sense economically either. You have to attend to this. And if I asked you to do that quickly, what are some of the factors you've experienced that make you feel less satisfied with your work? You just again quickly do that.
And Caroline, just on another note, not that it makes any difference because you are such a great speaker. We can't actually see your slides, but I didn't want to, it's okay, I didn't want to interrupt you because actually I was really enjoying it, and so was the rest of my subgroup. But please do, I don't know why it's not working, but everyone else, do please put some more comments in the chat as Caroline's figuring out the slides.
Why is that? That's I'm mortifying. You've only told me now. I don't.
We were all.
Oh, I know why. I think I know why. I know exactly why. I didn't. I just sort of launched in. I'm really sorry about that. You must have thought I was completely bonkers.
It's been great. It's been great. Don't worry. Carry on, please do.
Okay.
Just no one's brought any comments to the group, so just maybe repeat the question.
Okay, so what are some of the factors that you've experienced that make you feel less satisfied at work?
So understaffing, unsupportive seniors, lack of positive feedback, patient load being too much.
Yeah.
Angry parents, my
okay,
being rude, admin,
so if we then look at the literature, it's these factors, what efficiency and resources, you know, you just can't do the job with your resources available, or you're being asked to do things that don't make any sense. The overall culture of the workplace, workload, job demands, not enough control or flexibility, social support, community at work, and work-life integration. Just work-life integration, we know from research on PEDS, is really important. And I want to just have something to say about that, because the term we tend to use in the UK is work-life balance, and I think it's the wrong term. And I think it's the wrong term because if you think about old-fashioned scales, or the scales of justice, you have that idea of balance is predicated on the idea that the two things on the either side of the weighing scales are separate. If you have the image of work and life, or you might see image of it in being in balance, and that is the wrong image, because actually it's not about them being in balance, it's how they fit together, integration, because your work and your life are not separate. You bring stuff from work home, physically, sometimes in terms of actually things you have to do with, and other times it's in terms of mental preoccupation, and how you are at home is also going to affect how you are at work. So work and life are not separate. They need, and we need to be thinking about integration rather than balance. Okay, so I think that then, and Schoenfeld has got all sorts of different things about organizations can do, and I want to emphasize beyond anything else that this is what Schoenfeld and others research is showing, is that fundamentally burnout is an organizational issue. And yes, the issue of resilience is important, individual resilience, and we will come on to that. But alone, in a way, and you can think about it within infectious disease. Yes, somebody's own state of immunity is important, but you actually need to, if you're thinking about not necessarily COVID, but let's think about going back to the 19th century. Essentially, you needed to have sewage put in place. That there were things that were much bigger than the individual. Clean water, those sorts of things need to be put in place, and it's not just about that individual's immunity or that individual's how effective they are at washing their hands or whatever. And the same thing is true with this whole issue about burnout. Fundamentally, we are talking about an organizational issue, and we see that if we look at the drivers, and that is going to cost money. Now, Schoenfeld shows very persuasively, and it's American data, that it's money that is well spent. And that one cannot not spend this money, because it's an essential part of effective clinical care. But I think that going forward, you guys are going to be the consultants of the future. And you need to be challenging the rhetoric about this is individuals, this is the snowflake generation, the doctors just aren't quite robust enough, we are attracting into medicine doctors who are very, very clever, but they don't have they're not resilient enough, blah, 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 blah. We actually need to be talking about, seeing the organizational factors. So, this is about sort of doctors giving. I'm just slightly concerned about the timing, so I think I might leave that bit and come back to it if we've got time. But I now want to move on to just another way of thinking about this whole issue. Is that, you know, you are paediatricians, so you will be helping mothers with very new babies. And I think that there are ways in which we can understand the demands. There are things that we can learn from thinking about maternal care to understanding some of the psychological demands of being a doctor. Now, I am not saying that medical care psychologically is the same as maternal care. I'm absolutely not saying that, but I am saying I think that there are things that we just take for granted when it comes to maternal care that we overlook when we think about the psychological demands on you guys. So if we look at postpartum depression, we can see that's a situation where a mother is feeling psychologically overwhelmed. We know that the postnatal period is associated with increased disturbances in mental health. We know that actually it has an effect on the infant. But this is the crucial point. There's little evidence to support the biological basis for I'm not talking about postnatal psychosis here, I'm talking about postnatal depression. There's little evidence to support the biological basis. Instead, psychosocial variables, stressful life events in the past, marital conflict, and lack of social support. So yes, what's happened to that mum in the past is important, and previous depression is also a factor, but actually marital conflict and lack of social support, that's going to be, who else can the mum draw on for this new responsibility? And for the naysayers in the audience, there is actually post-adoption depression. And that again points to this, shows that this is about a psychosocial issue as much as a biological one, because an adoptive mum suddenly has these new responsibilities, and things that predict it are going to be about the amount of support that the mum can draw on. So how can we understand this? When we're tasked for caring for others, we draw upon our own experience of being cared for, both currently and in the past. And we need to know that there are people who both respect us and will support us. This is crucial for new mothers, biological and adoptive, and it's crucial for new doctors when they start having responsibility for patients. Plus, it's crucial each time they have a significant step up in responsibility. So basically, and we can look at this from an attachment perspective, but what's happening psychologically is when we have to care for others, our own experience of care is going to be activated in our brain, and we're desperate to feel that there are people around who respect us, who are conveying to us, yes, that we're fit for purpose, we can do this task, and we can also provide help and support when needed. And Gwen Adshead looks at this from an attachment point of view. But this doesn't always happen. This doesn't always happen. And medicine is unique, I think, in this was some sort of interactive map on specialty choice that Welsh Deanery did years ago, which always amazed me because the graphic looked at as if somebody was coming out of a manhole in the ground. And I never really wondered why the graphic designer had chosen as an image that when you pop up, you go to your next specialty for med school or special run through or whatever, you're coming up from a manhole. It seemed to me a very unfortunate image. Anyway, there's so many changes in medicine. There's so many transitions all the time. And we know from research on transitions, like it's in the public sort of the general knowledge, I think, the general psychological knowledge of the nation, that what's the most stressful thing in your life, the thing that has most psychological impact of a life event, death of a spouse. I mean, you know, I'm not talking about things like other horrors of trauma, of course that, but of kind of more everyday stuff, the life events that happen to people, death of a spouse. But if we look at this particular scale, Holmes and Ra, that looks at life events, includes things that change to a different line of work, change in responsibility, change in working hours, in residence, social activities, sleeping, number of family reunions, eating. Those are part and parcel of your working life. And these are changes, transitions, which have been shown to be psychologically disturbing, not all to the same. You know, a change in sleeping is not the same as the death of a spouse. But we need, buried in the psychological literature, is just this stuff about, yeah, transitions can be psychologically demanding. We know that. But nobody's applying that to medicine, to thinking about how many transitions are you taking. And I think that without being accused of looking backwards with rose-tinted spectacles, we need to look at the ways in which there's been an erosion of supportive relationships. So larger medical school intakes, foundation doctors move all over the country. When I talk to doctors, I'm 63. When I talk to doctors, if I think of my own friends who are medics, or if I talk to doctors who are kind of coming up to retirement, how many were in your medical school class? When you did your house jobs, were you in a hospital that you knew already? Did you know the other people who you were working with in your house jobs? How long was your house job? 6 months. So you had time to bed down, get a bit of a sense of you know what you're doing. Now they're 4 months. If you're very unlucky, they're 2 months. How can you build up a sense that you really know what you're doing? You're fit for purpose in 2 months. You live off site, the removal of the mess and the old style firm. Now the firm wasn't perfect. Of course, it could be if it was dysfunctional, toxic. But when it worked well, it was a network of support. And we also need to factor in the issue of racism. I was very gladdened to see that Dame Claire Marks, the president of the GMC, in the most recent GMC, the State of Medical Education and Practice, you know, actually said this is the #1 priority. And it absolutely is the #1 priority. So when you start to look about what's going on psychologically, I think that, and the changes, the shifts that have happened, I think that we can put paid to the snowflake hypothesis, that this is this burnout is due because we're just not recruiting the right doctors. you know, that's not to say I do see some people who shouldn't have gone into medicine. Sorry. And I do see some people who are in the wrong specialty, yes. But much more common is people who should be in medicine, who are not, where the system is not giving them the support that matches the inevitable challenges. In the book, I also talk about, and I'm going to talk about this very briefly, about the difficulties of being both a doctor and a patient, the stigma of mental health. But I think that this is something also that's relevant to peds in a way, because I think I've had peds trainees talk to me, paediatric trainees talk to me about how different it is to be a paediatrician when you've got your own kids. You look at the world slightly differently, and you know, it's alarming if you have a seriously unwell child, a child who's had maybe an accident, or a child who's got some you know, is seriously unwell, brain tumor, whatever. It's going to remind you that those things could happen to your kids. How could it not? And I think I doubt there would be, for those of you who are parents, mums and dads, I would be surprised if any of you thought that having children of your own hasn't had an impact on how you experience your work psychologically. So and yes, and finally in the book there's a chapter on which I call leaky pipes, because it comes from a great paper on women in surgery, but and it comes from the fact that there's a lot of talk about retention, which is phrased in terms of leakage from the system, and the writer talks about the fact that when we're talking about predominantly women who find balancing childcare and their professional responsibilities so difficult that they leave the medical workforce, the conversation is always about the water, i.e. the women leaking from the pipes, not about the robustness of the pipes themselves, i.e. the system in which they are contained. And she wants there to be much more emphasis on the pipes rather than on the water. So some tentative conclusions. Medical work's emotionally demanding, but this psychological aspect is often overlooked in medical training. I now have the very interesting experience that my middle child, I've got 3 kids, who's 31, about to be 32, who read English at university and then did a PhD in English literature and started off on a career as an English academic, just decided he was going to do medicine. Hadn't done any science since GCSE, and he is now in his 2nd year at Warwick. So it's very interesting. I never thought I didn't think I would be a medical mum, but it's very interesting to be the parent of somebody who is in med school. And I'm very interested to hear, you know, how they support him, how they explain different, you know, what it's going to be like to be working as a doctor. Different specialties impose different psychological demands. We haven't really touched on that, but I'm happy to take questions. Yet support for identifying a suitable specialty can be poor. Transition points can be particularly demanding. Doctors can be moving to new parts of the country where they have no systems of support. In terms of reducing burnout, well, individual resilience has a part to play. Far more important are team and organisational factors. Interventions need to be devised at this level rather than solely focusing on the individual, not only on a practical level, but also on an emotional level. Being a paediatrician can become harder when you become a parent. So Tate Schoenfeld has in one of his papers an analogy is, you know, if people are working on building sites, we get them to put on hard hats. So what are some of the hard hats that you can put on? I think the first one is is this very overused analogy, but actually it's overused because it's spot on. We know that on a plane, if you're traveling with a child and the oxygen masks come down, you've got to put your own mask first, because otherwise, if you try to deal with your child first, you will keel over and then you won't be able to help your child and both of you will suffer. And we absolutely need to be, you know, giving this message from day one about it's not an optional extra to look after yourself, to take care of yourself. It is absolutely essential. And part of that is asking for help when you need it. And you know, that's, and I saw the resources that you've been producing, and that's fantastic. And we are very lucky, I think, in London. When I can't think what I was doing, but I was doing something in the East Midlands last week just to talk. And luckily the practitioner health programme, luckily Doc Health, those are now national services. But the range of supports, I still do freelance work for the professional support unit. There is a lot of help out there, good help. Let me just think, paediatrician. I'm just trying to think why, let me just have a look. I've suddenly lost my train of thought why I've got that slide in there. I think, yes, I remember now. That is about being a good enough, Donald Winnicott had a very famous phrase about being a good enough mother, not being the perfect mother. And you have to be good enough to paediatricians. Perfection is the enemy of the good. And in talking about the good enough mother, he wasn't, you know, to put your toddler in the bath and then to go downstairs and pour yourself a large glass of wine and switch on the telly. That is not a good enough mother. But you don't always have to, you know, be making homegrown organic food, which you're there's a middle way, and that's with parenting, and you need to have a middle way. There are things as a doctor, as a paediatrician, that absolutely have to be done, and then you have to learn the other things where you can be good enough, a safe, caring, competent paediatrician, but not perfect. You need to think about the positive things, and it's very easy to say, but I know at difficult times in my working life, I have kept and it's just private for you. If you get a lovely email from, or a card, or just a comment from a nurse or somebody, you know, one of those lovely kind of unsolicited positive, I'm not talking about when you ask for 360 feedback, it could be from that, but more something random and unsolicited that is really positive, keep it, jot it down somewhere. I heard a talk in Edinburgh of a guy who had of a consultant who had a very major breakdown and had been off work for a long time, and he talked about all sorts of things that contributed to his recovery and ability to return to work, and his writing down positive things was a part of that. And I think it's a very small, quick thing to do, but it can be, and some people do it by writing down 3 positive things that have happened every day, and that's certainly a valid thing to do. But I think what I've found helpful in the past is this just kind of collecting just positive things, a little personal folder. And I know when things like when my book was published and Henry Marsh, the neurosurgeon, thought it was a load of crap and wrote a horrible review in the Times, the fact that I'd had lots of other reviews, and more importantly, you know, hundreds if not thousands of letters from doctors saying this really makes sense, this describes my experience, including one very funny one that said, I can't believe that you, I mean, it was a joke, but you know, you've written about me, you've included all my experience, even though we've never met. So somehow because when we're depressed, when we're burnt out, then cognitively we tend to focus on the negative anyway. This is a decompression chamber, and I think that we need to get more adept, everyone, at recognizing our own, what decompresses us. What is it that just helps us switch off, become more whatever it is for you. It may be baking, it may be going for a run, it may be doing something crafty, it may be something musical, it may be just watching, zoning out and watching a box set, it may be whatever it is. We need to know what it is, and we need to factor that in. Sleep, I heard, was being talked at. As it was being talked about as I came in. And I suppose now really it's a question of whether anybody's got any questions.
Great, thank you so much. Guys, if you all keep.
Oh, I can now, can't I? I can stop presenting.
Yeah, and we do have some questions, so I'll bring them forward. So Nigel is the first person who's in the group. He said, "For Caroline, loved your completely fascinating. Seems to me there are a lot of paediatricians in it. Did you see more paediatricians than you might expect compared to other specialties? Why do you think?"
Okay, I did see more paediatricians, but Camilla Kingdon, who was the head of school, well, Andrew Long, who was the previous head, was very interested in careers. He was the careers lead for the deanery, and he was one of the ones who had sort of poached me from KSS to London. And then Camilla Kingdon, also interested in careers, and for a while we ran a master's with the University of Brighton on sort of medical career coaching. It's no longer run, but we ran a master's. Camilla did the master's with me. I was her master's thesis supervisor. She got a distinction, you'll be pleased to hear, but unsurprised. So yes, I did see more paediatricians, but in part that was because both heads of school were very, we worked closely together. In comparison to, I can't remember what his surname was, but the head of surgery, who I saw very few surgical trainees, and I would email the head of surgery about different things from time to time. He never responded. So in the end, I tried to get him on the phone. I mean, I was a salaried member of the deanery, as was he, and I got his PA on the phone, who said that he never answers his emails. So he that was his thing, never to answer his deanery emails. So what I'm saying is the ecology, the deanery, not the ecology so much, the network of deanery relationships would have had a big impact on why I saw so many paediatricians. But I think there's a chapter in my book on women, paediatrics, as is obs and gynae, but the head of obs and gynae, Greg Ward, was also a good pal. So I saw a lot of obs and gynae trainees for the same reason. I think that, you know, I have this image of the medical, it didn't go in my book because I couldn't kind of explain it very well enough. But if we think of the system of a production line, which is producing doctors, which is taking in as its raw materials, either 18-year-olds or it's taking in graduates, and then it's bit of the factory line is med school, and then it's all the postgraduate stuff. I have as a model the idea that if we compare to those who are coming up to retirement now, my age, the inputs into that system have changed. They've changed in terms of gender, and they've changed in terms of ethnicity. Alas, they haven't changed that much in terms of social class, because widening participation in medicine has been rubbish. But they've certainly changed in terms of gender, and they've changed in ethnicity. And then if we look at the output, the actual jobs that the output of this production line are going to be put into have changed beyond all belief in all sorts of different ways. And yet the machinery of production has largely stayed the same. Now, if you were producing china or something, if you were producing china plates, and you had different raw materials going in, and these plates were being used for a radically different function, you probably would have to change the machinery, the production process. But it hasn't happened. It hasn't happened adequately. So I think there are issues that women face, and there are issues around gender, and that there are significant issues around race. So I think another reason why I saw lots of peds and lots of obs and gynae was that those are both have got a lot of women in it, and I think that both wanting to work with children, wanting to deliver babies, there can be somebody, one of you talked about how much you liked working with children, but of course there's a flip side. As a paediatrician, there's a flip side as an obstetrician, that you if we think of the Charlie Gard case, it's not all plain sailing. You can encounter some really, really, really difficult situations as a paediatrician, as you can as an obstetrician. And I think the whole spectrum of experience that you will have to get your head around as a paediatrician and as an obstetrician isn't, and whether you're suited to that, I think that's not necessarily laid out.
Thank you, Karen, for the insight, that analysis of the time. A few more questions, time for them. Rachel said, wonder if there's done about the experience.
I can't hear, Nisha, you're breaking up.
Oh, okay. Can you hear me now?
Yeah, say it quite slowly.
So Rachel said, I wonder if there has been work done about the lived experience of pregnancy, childbirth, doctors, and certain specialties, perhaps any or GPs. It seems from her own experience of that of many female members who have had pregnancy, that they are disproportionately affected by fertility issues, miscarriage, anxiety in pregnancy, and birth trauma influenced by their career.
Okay. I don't think there's been much done. I have a GP colleague who had a number of GP trainees with fear of pregnancy, tocophobia, and I did look for her in the psychology, and I couldn't see anything. I suspect that for fertility issues, you may have to be you'd have to sort of compare yourself with age. If women have delayed pregnancies because of the long training, I suspect that anxieties are higher. And why wouldn't they? Definitely, why wouldn't they be higher? In a way, they couldn't not be higher, because you are seeing, if you're an obstetrician or a paediatrician both, you're going to be seeing the more complicated stuff. So that is going to be in your head of the range of ghastly things that could happen. So I suspect that anxieties are higher, and those will be confounded by working past the date you probably should be working by all the things about the perfectionism, by the unyielding system, all that sort of thing. One of the things that has not been looked at, which I find unbelievable, is eating disorders. There's almost no, and I have, and this is something that Camilla Kingdon and I have talked about a lot over the years, because we've seen a number of doctors, including quite a number of paediatricians with eating disorders. And some of the doctors with fertility issues that I've encountered had eating disorders when they were younger. And obviously there's a link there. So I think we don't know, but something is going on. And I certainly have encountered a lot of doctors with fertility issues, a lot of doctors with some with recurrent miscarriage. And you know, I'm this is not my my PhD was on psychological aspects of pregnancy, but I don't know about miscarriage and fatigue, miscarriage and working night shifts. But you know, perhaps there's that sort of link too. But that is pure speculation. I don't know. I've probably got time for one more question.
Yeah, definitely. A little bit of feedback. I can only apologise. So Ciara has asked, looking to junior doctors and medical students. So she's said thank you very much for the book. She really enjoyed it. She was wondering if you had any thoughts on how we can make medical students or junior doctors aware of different and less travelled career paths.
I mean, it's when I was the head of the careers unit and had to run careers events, it used to drive me bonkers that the people who would want to come and sort of have stalls would be the gastroenterologists and the respiratory medicine and the this and the that. And it's in a way, it's a bit like orphan diseases. We need more attention on orphan. I mean, you know, that would not be a way of those people who are working in very small specialties. My quickest answer is, and this will be, you will hate this answer, but I will give it anyway, that the elective needs to be reframed, not to be much more, which is what happens in the States, and not going off to Borneo and lovely places or Bonsai Beach or Bondi, wherever, that actually that should be much more not around choosing your longer term, but around an option at a time to really explore different, you know, 6 weeks, 8 weeks, where you can read about and maybe go and visit all sorts of different possible career options. But I think that I have had, and I did write about it in the book, occasionally I've had the experience of, you know, things like paediatrician, somebody wasn't coping with acute peds, a couple of people going into audiovestibular medicine or going into clinical genetics or something like that. And it needs much, much, much greater attention so that people are aware of the very small specialties, and people are aware of sort of taking your medicine, your clinical qualifications, but be it with a drug company or an insurance company or the Foreign Office or something, taking your medicine and doing something non-patient facing with it, even if you have got your CCT.
I think that's a really interesting point, actually, Caroline, because the amount of looking back now and also thinking about when I was 18 and making these big decisions, like you only thought doctor, lawyer, banker, those are the only sort of categories, and you realise there is so much more out there. But you know, like even my brother has said to me that you should have become an event manager, but you don't think about that until you're in the real world, because you're so encompassed.
Yeah, you don't know about it, and yeah, I mean, and that's obviously a bigger question about career stuff in schools and whatever.
But yeah, so great talk. We probably have time for another question if anyone does have one. Anyone want to come forward with any other questions for Caroline? Well, I'll leave it open there, so there are things there, but I just want to say thank you so much, Caroline. That was such a powerful and inspiring talk, and it really posed some important questions. I think thinking about such great aspects, which we will hopefully cover some of those today. I loved the work-life integration, and I loved the change in our way of thinking about that. I've tweeted it already because I'm so enthused by it, but it's so true. And you know, the transitions, I never really thought about how these transitions really do impact burnout, from just starting a new hospital to
and there is nothing, although interestingly yesterday, when I have always thought there's nothing like medicine, just talking to these psychologists and coaches of elite athletes, that randomly for my book, they asked me to come and do this brief talk. They're often moving around. Like they talked about footballers who haven't quite made it to the Premier, to the top league or league below, and they're moving around, and that really interested me about some of the parallels psychologically. And actually we need more of those, because we need to deconstruct the exceptionalism of medicine.
No, absolutely. I completely agree with all of that.
I've got to go back, and now I've got to go and be granny, because my grandson's in my support bubble, so I've now got to go and relieve my husband and get back, and that's why paediatricians do.
Lovely. So guys, we're going to go on to our next talk, which actually follows on so lovely from Caroline's talk, and we're going to go to Dr. Claire Gallagher, who is a GP and also my personal practitioner health counsellor, and I approached her today, approached her a while back to come and talk to you guys about some CBT tips and how to look after your mental health. She's really helped me over the last year and a half with everything that's been going on, and I really wanted her to come along and share all of her experiences, which you can see in the programme. She's got plenty of. So I'm going to hand over to Claire, who's going to take over the next part of the talk. Claire?
Oh, hello. Hi. I'm just waiting to see if the slides are coming, Nisha.
Get in the map.
Please.
Yeah, no problem.
Oh, that's wonderful. Thank you so much. Thank you so much for inviting me today. I'm just delighted to be a part of your day, and I was very pleased to listen to Caroline's talk, which was so informative. And Caroline and I have overlapped at various points over the last 10 years whilst I've been working with practitioner health. I have a GP background, and I also worked in an eating disorder service for 10 years, and then more latterly combined that work with becoming a GP specifically for practitioner health. And something that Caroline said that I would just so like to reiterate is this business of addressing organisational stressors and paying attention to those is absolutely the key, most important thing that needs to happen to protect everybody's mental health. I'm thinking, about the NHS as the wider organisation, and then the organisations within which people work and the departments and so on. And I still get people telling me the biggest thing that makes the difference is to be on a rota that's workable, to have the rota 3 months before they start, to be able to plan their holidays, and things that really make a difference to being able to replenish properly. Doctors aren't short of ideas about how to replenish. It's just more that, when people's when things aren't so good from a mental health point of view, following stress at work or at home, the normal coping strategies that people tend to use aren't as easy to access. And of course, with COVID going on, we've also got sort of a severe lack of freedom to choose to do the things we would normally do. So I'm going to cover that. So I think I just want to reiterate, I too agree that is the most important thing, but then to sort of concentrate on the fact that I'm thinking about this from a personal perspective, an individual perspective, and sort of how to formulate what people are dealing with on an individual level and CBT tips on an individual level. So whilst acknowledging how important the wider organisation is. Next, please, Nisha. Thank you. So just to say, I'm from Practitioner Health, and the website is there. And we've come towards the end on some of the resources that are available on the website. and some of the aligned organisations that we work alongside. And I know that Nisha shared with me the flow chart that's going to be shared with everyone about sort of how to consider where the problem lies if people are feeling overwhelmed or they are feeling there's a problem, so that people can best access the most appropriate help. And we're not an acute service, so the out of hours number is 111 or 999 or going to A&E, and we'll come on to that near the end as well. And I'm going to keep talking and then save the questions for the end, but definitely am saving some time for questions at the end, so look forward to hearing anything that you think of as I'm going through. Next please, Nisha. So just the overall plan, thinking about these unprecedented times we're in, thinking about the frameworks or models that help us to consider the problems that somebody's facing. There's a typo there, it's meant to say case studies of ST2 and ST6, and just reiterating those are fictitious case studies, and just really summing up a variety of problems that different people frequently bring. And then thinking about CBT techniques, and I'm going to hone in on a couple that I find so helpful. And people often say to me, if they've seen me as their lead clinician and then they go off to have 8 sessions of CBT, when they come back, I often say, and what have you found most helpful? And they say, well, it's just 2 or 3 things, but I do them every day. And I can really sort of relate to that because, I've been remote working during COVID, sitting at a desk in the loft most of the time. And I've had great plans for daily walks, and it's just so easy for that to sort of fall by the wayside and stay indoors and think just one more email, just one more phone call. My daughter, who's home from uni at the moment during lockdown, says to me, Mum, have you been for a walk? And she sort of puts my trainers by the door and pushes me out the door and gets me to do, little loop of 10 minutes or 15 minutes or whatever there's time for. So I know how helpful it is to have someone else who's interested in, is it happening? Are these simple things able to happen? And then touching on activity scheduling and a specific model by Maury, then something to do with the University of East Anglia's checklist and thinking about resources at the end. Next, please. Thank you. So normally when I give this kind of talk, which might be to GP trainers or trainees, or it might be hospital doctors or doctors working for our service, and so on. We normally talk about the fact doctors have the same problems as everyone else, and then they also have the additional stresses relating to their role as a doctor, which Caroline did a brilliant job of covering various points. And I'm thinking of this in terms of emotional strain at work, of what people deal with, and specifically for you as paediatricians, I'm thinking about you breaking difficult news to families of, untimely cancer diagnoses, or dealing with safeguarding issues, and the emotional strain that takes. But also in our private lives, we still remain the doctor. If a member of our family's ill, we might be the one that other people ask to interpret what's going on, or it's hard to be a normal patient because we might be asked, what would you like to happen? What do you think we should do? But now we've got this additional stressor of COVID to deal with too. So it's an even more complicated situation than usual. I want to sort of bear that in mind throughout our time together. Next, please. So just thinking about some of the things people have talked to me about in this last year of COVID. So to start with, there was huge anxiety about catching it, PPE, and safety of vulnerable relatives, and going home to people and needing to take clothes off at the door and wash carefully and this kind of thing. Uncertainty's been a massive theme about exams being postponed or the nature of the exams changing, about training jobs, progression, planned consultant applications, planned out of programme time. And then there's been frustration about ever-changing protocols, redeployment. This feeling underutilised one really related to the first lockdown, and often people in foundation programmes being moved from one department to another, and people having a strong feeling they wanted to play a part. But I'm thinking in paediatric terms. I've heard about, you know, paediatric ICU beds being turned into adult beds, and people doing liaison work, which is, understandably very stressful. And then distress. Again, this is often people who have been moved to look after adult patients. The witnessing of shortness of breath or increased deaths. Then anger about communication, about team dynamics. And then this is another big one, concerns about the future, both personally and for the world. And in the year that we've had, and the whole Black Lives Matter last summer and ongoing, and the way in which our world has changed and how we spend our spare time and our holidays and all of those things, really, it gives people a lot to focus on if they are at home and worry or rumination come in. So I'm going to go on to that again in a moment. Next, please. So just thinking about CBT models, and we'll go again to the next one, please. This longitudinal one, I just find so helpful. And Butler described the struggle is to find a way of seeing things that helps. And in CBT, the idea is to sort of have a roadmap of where the problems have come from, and also what are the useful things to focus on doing. So this 5 Ps model, which Dudley and Kaiken first described, thinks about predisposing factors, including things from childhood and early experiences, the precipitating factors or triggers right now, the protective factors about what helps, and perpetuating factors about what's keeping the problem going, which includes safety behaviours. Next, please, Nisha. So this is what it might look like on a piece of paper. And I've got a colleague called Simon Line, who's a great CBT therapist with our service, and he folds a piece of A4 into 4 and puts these categories into the 4 corners and the problem in the middle. And I've started doing it too with people, because people often say, well, after the end of the first session, what was most helpful was just thinking with an objective person, thinking about the problem and laying it out. And people often say, gosh, I didn't realise I had so much on my plate, and the top right hand corner can be really heavily burdened with factors. And people think, well, no wonder I'm feeling like this, no wonder I'm overwhelmed. And then people often also say to me, and I like to think I need to do more of bottom right hand corner or less of bottom left hand corner, and we'll go on to those in a moment. But I can identify with that too, and I have my things in my bottom right hand corner, like the walk and the trainers by the door, that help me. So thanks, Nisha. We'll go again. So this case study, I just thought we could consider it in terms of an ST2 male GP, paediatrician, and thinking about predisposing factors, having a feeling of responsibility, wanting to contribute during COVID times, but really, in this time of low mood that this fictitious person's experiencing, with lack of motivation and fatigue, having feelings of I should be able to cope, but more of a feeling of I'm a failure, other people are stepping up, I can't face it. And then looking at the factors, maybe there's been a complaint relating to a child death on call, more safeguarding cases on call, their exams being postponed, they can't go home at weekends, which was something they used to find really relaxing and replenishing because their parents are shielding, the gym's shut and no social plans, nobody to meet for a drink after work, no meal together, nobody to join up with at the weekend. So really tough. And looking at the perpetuating factors, what I often hear from doctors is that they're great at keeping the show on the road when they're at work, and they, really pull it out of the bag and do everything possible, everything they need to do. But on a day off, if they are not expected anywhere and don't have any commitments, there's this tendency to think it's safe, it's nice to stay in bed, don't have to be anywhere, safe under the covers. Increased scrolling through social media maybe, or just drifting in and out of sleep in a sort of unreplenishing kind of way. And then in the evenings, maybe more alcohol than usual or more takeaways. So a general not feeling good by the end of it. And rumination being a very core cognitive process, which I'm going to address shortly. Then looking at the protective factors, things like exercise, phone a friend, but particularly daytime routine on days off is so helpful. And I'm going to come on to that. And also from cognitive side of things, the idea of a breathing exercise. And I know, or a relaxation exercise or attention switching. I know there's a session at the end of today that's focusing on that, and that ties in so well, because in the old days of CBT, people were often encouraged to think of the thought or the way somebody's looking at it, which can be a bit distorted whilst low mood or anxiety are there, and then think of a more helpful way of looking at it. And whilst doctors tell me, well, I can do that and I can think of it in theory, but I don't believe it. You know, in the moment when I'm not feeling good, I believe the one I believe. So this is where it's so helpful to learn this technique to detach, and I'll come on to that. So if we look at the ST6 example, Nisha, thank you. This person actually, fictitious case of feeling anxious and overwhelmed, and doctors often tell me, no sooner have I dealt with one anxiety and feel I've put it to rest, the next one pops in and I'm stuck with another that I go over and over. People also tell me they overthink things, and this might be, did I do the right thing? Have I covered all the bases? Or it might be in their spare time, what does it mean that so-and-so hasn't got back to me on text? Or have I upset somebody? Or do I have enough friends? Do I have any friends? You know, the whole situation we're in is very sort of disconnecting really from our normal lives. So this person might say, well, I've always been a worrier. I like planning ahead and I like being organised. And my mum was the same. Now, many of these things are great in terms of being organised, and a planner is a great attribute as a doctor. And it is great for the patients and great for your colleagues. But you know, there does come a point where it's not efficient problem solving kind of planning ahead. It's sort of burdensome, and we're going to touch on that. In contrast to this sort of, my mum was the same, sometimes people have had two laid back parents and the oldest child ends up having to plan for the family because no one else is doing it. So somebody might say to me, oh, everyone else wasn't paying any attention, so I had to worry on behalf of everyone. Then precipitating factors, this person, fictitious case of being redeployed to do family liaison work in ICU, phoning all the families to let them know how their loved one was doing today, which, you know, is incredibly draining. And, you know, I can only imagine how hard that is. Meanwhile, they have two children of their own, childminders left, their parents who would normally help with backup for childminding are shielding. Their frontline partner's just got a consultant job in another bit of the country, so staying away some of the week. This person might have a consultant interview pending and trying to do a course, squeeze in a course to learn how to do that, and their exit exam too. So perpetuating things, they've started watching more news, checking their emails more. At night time, maybe when the children are in bed, finding themselves binge eating to sort of distract themselves, and worry being the core cognitive process we're going to come on to. So thinking about the practical side of the behaviours that are protective, sort of thinking carefully about problem solving. This person had, you know, for a fictitious situation like this, needs to get new childcare in place pretty quickly. Making a timeline of these many, many jobs that need doing, and then scheduling the to-do list against the deadlines. So booking in the consultant interview, practice, weekend course or whatever. Scheduling revision for when a partner could help with childcare, planning healthy meals and snacks, but really important to be realistic about what's possible. No great big meals from Nigella, but you know, something much more simple and basic. The old tried and tested favourites that are there, either a batch cook from before in the freezer. But I mean, that's my dream, that somebody would fill my freezer with lovely batch cooked meals. And then again, the kind of cognitive thing to help, attention switching exercises, which could be something like look for 4 things, listen for 3 things, touch 2 things and smell 1 thing. Or it could be listening to sounds as the main thing that you're helping to detach from being in the moment. So I'll go for the next slide, please, Nisha. I hope I'm not speaking too fast. This is slightly blurred, apologies, but it's called the hot cross bun model in CBT. And really, focuses on in the moment rather than the longitudinal one we've just considered. This one's more about right now, when somebody might be, say, under the covers on a Saturday morning, not feeling good. What are the thoughts? And actually, I'll go to the next slide to expand. They might notice I'm not feeling good, but then the next question to ask is, what is going through my mind? To actually capture the thought. That then might link to the behaviour that follows, that is, what's the point? There's no point getting up, there's nowhere to go anyway, and staying in bed, and linking to how someone feels and any physical sensations. So we'll go on to the next slide, please, Nisha. So they might think it's all out of hand, there's nothing I can do, you know, I can't see anyone anyway, and stay in bed with flat and apathetic feelings, and maybe feeling more lethargic. And instead, if we go on to the next slide, there's a really good webinar which is on our Practitioner Health website, and you click on COVID-19 workforce wellbeing button on the front page, and there's 6 little rectangles, and one of them is webinars and podcasts. And one of my colleagues from work, called Caroline Walker, who's a psychiatrist, she has done one about managing anxiety in COVID times, and she talks about, what do I know today in order to help? What can I do today as the follow-on? So it could be I'm home-based on a day off, so I need to get through some tasks, and it might be shower, breakfast, computer jobs, walk. So not earth-shattering, but they're things we all kind of have on our to-do list. And that can then lead to a feeling of feeling productive despite the restrictions, and physically feeling a bit invigorated by the shower or the walk. A phrase I've found people tell me is helpful is, if they're feeling really lacking in motivation and can't be bothered, which is very common in spare time, people might use the phrase, all I have to do is, and then follow on with post this parcel, or get to the recycling place, although even that you have to plan ahead for these days, so it's not quite as simple as it used to be. So if we go on to the next one, but I do love going to the recycling centre, it's one of the best feelings. Moving on to CBT techniques now, and the next slide, please. I think targeting these 2 core cognitive processes that are keeping the low mood and the anxiety going. So rumination being looking back in time, and the human brain trying to examine, what did I do wrong? Why did that happen? Could I have done it differently? We're always searching for the answer, which in itself seems like a good idea in a problem solving kind of way. But actually people often dig deeper into the hole, and they don't come out of couple of hours of ruminating thinking I feel so much better. They usually feel kind of more in the hole. And with worry, that's more projected into the future, like what if this happens or that happens. And people often think I'm stuck with these. And if we go on to the next slide, please. Whilst we can't stop the thought popping in the first place, we can control what happens next. So rather than a day spent in bed ruminating, we can take control now. The thoughts popped in, so we might be feeling flat or feeling anxious, and then we think, what's going through my mind? So you identify it. Then you think, can I problem solve this? And if so, now or when? For example, what if I'm not prepared for my interview next week? So we could actually decide, right, when can I get organised for preparation? Would that be Wednesday on my day off, or afternoon off, or would it be the weekend? And what will I do? Will I speak to somebody who's been in the job before? Will I ring the department? Will I read around it? And that's a problem solving approach. And then when we've done all the problem solving we can, if the thought pops in, what if they're mean to me at the interview next week? Can't do anything with that. So we can identify that as an unhelpful thought and decide it's time to detach from it by using some sort of attention switching technique. So some people might put on nice music, some people might do a bit of a crossword, some people might do a breathing exercise like hopefully is coming later today, and or some sort of listening to sounds. So we'll go for the next slide, please. And I've just jotted down a few mindfulness resources which people have fed back to me, and I've tried them as well. This book I particularly like, by Penman and Williams, Mindfulness, Finding Peace in a Frantic World. And it's got a CD at the back, and I think there's an app you can pay an extra £5 for. And it's got a 6-week kind of programme where you spend a week with each chapter, written in a really nice tone, and kind of just suitable for everyone, for anyone. And it really depends whether you like the voice of any of these CDs or apps. And Headspace and Calm are two of the examples. And they're also on this COVID-19 workforce wellbeing button on the front page of our website. And if you go to the apps button, they give information about how to join free during these COVID times. So next slide, please. So I next want to just focus a bit about activity scheduling, because if I could only have one technique for low mood, that's a talking therapy kind of technique, this would be it. And really, it's focusing on the idea that you split the day up into morning, afternoon and evening slots. And some people go even sort of more detailed into hourly slots. And then you think about activities that could go in those slots. And then you rate them for how productive, how enjoyable, and some people also rate the mood. And the idea is not that we should be doing something really enjoyable all the time on our time off, because, you know, even if somebody loves watching films, watching them 24/7 does become boring. So I must say, I'm just thrown into mind the Surviving and Thriving handbook, which I absolutely love, the Paediatrics handbook that you've created. And I love the top 10 films, and I've heard psychiatrists getting together to discuss films as instead of journal club, it's film club, and thinking about what attributes of the film inform their life as a psychiatrist. And I just think, you know, these things are really enjoyable, but also you need some productive tasks in there, like clear out a drawer or sweep the leaves or whatever. And the idea is not to actually have to enjoy them or to feel they're productive. It's the first aim is just to do them, simply to do them. And it throws into mind somebody who I once spoke to, and he said I could share this story. Obviously it's anonymised. I was asking him, what did you used to enjoy doing? And it was running. And he was incredibly, you know, feeling really low and no motivation. He said, but, you know, what's the point? You know, I won't know anyone there. And he was thinking about joining a running club, found one to join. And a few weeks later, he said, oh, I'm only going because you want me to, Claire, you know, I still don't go out for coffee with anyone. And, you know, but a few weeks in, he started saying to me, actually, it's reminded me I really love running and I'm actually quite good at it. And also there are no doctors there. And I don't have to talk about medicine, and I just don't have to organise it myself. It's there every Wednesday at 6 p.m. And if I can't go because of work, that's fine. And if I can go, all the friendly faces are there. So that was just such a good example. And he afterwards said that was the game changer for him. And there's a great link there to a 35-page resource from the University of Michigan. And it kind of takes you through behavioural activation step by step. So I highly recommend that. And we'll go for the next slide, please. This one is Maury's flower of depression, but then following on with a virtuous flower. So this one, you put depression in the middle, and the thoughts might be I'm a failure or I can't cope. And he chose to name each petal with a different kind of negative thing, like negative automatic thinking or ruminations or withdrawing from things, not contacting friends, and so on. But if we go to the next slide, the virtuous flower would have healthy things. So if we're thinking about the longitudinal formulation I mentioned earlier, the bottom right hand box with the various helpful behaviours or helpful cognitive strategies could each populate a petal. And this brings to mind a psychiatrist who also said I could share the story, although it's obviously anonymised. He brought out one day a folded up small piece of paper from his back pocket, and he said, Claire, I'm still doing it. And I said, oh, what's that? And I couldn't even remember doing this exercise with him, but he brought out a flower with his preferred behaviours on it. And he said, from time to time, I just think, well, I'm doing those petals, but I could still work to do on that one. And he said that was the game changer for him. So that's why I've shared that one. And if we go to the next slide, please. This is a checklist. I'm almost done, so I'm leaving time for the questions. This is from the University of East Anglia, and they developed, some students developed an app to help low mood and anxiety, and it's linked to a mood tracker, and it's just brilliant in its components, because it kind of touches on most of the things we've already spoken about, but in a really nice checklist. And I often find myself thinking, gosh, well, I'm doing A, B and C, but I've forgotten about this one. So it's plan ahead, reframe, exercise, seek support, problem solve and modify mood. So the reframing would fit very much in with traditional CBT methods about, I'm thinking about it this way, but I might have the blinkers on because it might be the negative type of low mood kind of way of looking at something. But how would I advise a friend? And usually as doctors, people are great at being able to think what the solution is for other people, and also to be very compassionate and kind to their friend. You've got so much on, of course, you know, it's too much for anyone, you know, it's right to seek help now. And then just touching on the modifying mood one, that tends to be too much of, and then it's either alcohol, drugs, could be social media, could be watching the news. Then it's so isolation is the too little of, so too little contact with friends. And of course it is difficult on Zoom, but some people are doing walk and talk with a friend on the phone when they go for a walk. But even just booking in to know once a week I'm going to choose a different friend and, you know, touch base with them in these times where we are so limited with what we're able to do. And then on the exercise one, I've been quite inspired by all the different doctors telling me what they've been doing in lockdown and thinking, gosh, all I'm managing is my 10-minute walk. But, you know, somebody had hired a rowing machine instead of their gym membership. Somebody had bought a turbo trainer for their bike and was connecting to a Peloton app / laptop Peloton thing, because the Peloton bikes, I think they're amazing, but very expensive apparently. Somebody got a new dog, which obviously is amazing if people have got the capacity to keep looking after it after we're out of lockdown. So all of those things kind of do a full circle back to these techniques. So could we go to the next slide, please? Just like to touch on the fact that if somebody does feel in crisis or unwell, unsafe, it's really important to seek help through either an emergency call to 111 999 or your own GP or A&E. And PH have teamed up with NHS Wellbeing Support, and there's a 24/7 text crisis service where you text NHS PH to this number 85258, or you can text Frontline. And then there's also the Samaritans. And I also want to point out, you know, practitioner health is NHS confidential service for all doctors and dentists in England, and since the 1st of January in Scotland too. So anybody can self-refer, and the number's on the slide near the beginning, and you can do it by email or by phoning. You fill in some questionnaires, and then you get the choice of your being able to choose which lead clinician you like the profile sounding, to choose who you want to see for your first contact, and you remain with them. And then people may be referred on for CBT sessions or peer support through our service and various other options. But really just, you know, now honing back to the flowchart that Nisha shared with me, and it just so nicely pinpointed that there are different sources of support. So professional support unit, exam support, physical health, and then thinking about from when people are feeling there's something going on that they do need help with from a mental health point of view. There's ourselves, and then there's Doc Health, which is consultant psychiatrist providing a psychodynamic psychotherapy approach for a reduced rate for up to 6 appointments. And then obviously I'm just going to check my little list, BMA 24/7 counselling service for doctors support, and then Sick Doctors Trust, Doctor Support Network, and all of these are listed on the PH website under the other sources of help. But also things like an NHS bereavement helpline. HEE has great COVID-19 hub, and they even offer to help people identify what resources might suit their circumstances, so between groups or individual things. But also Mind website, NHS website, and then some wellbeing service websites, and also financially, if things have become a problem, if people have a partner whose job has been affected by COVID, thinking of the Royal Medical Benevolent Fund, also documented, and just thinking about types of interventions. Apart from the apps and webinars on our website, there's also PDFs, and a particular one to draw your attention to is Living with Worry and Anxiety Amidst Global Uncertainty, which just really joins in with what so many people have on their mind and have had on their mind through this difficult year we've all been through. And thinking ahead, what do PH want to help provide people with? You know, people are thinking about setting up some decompression groups to help deal with the stress of what people have been dealing with all this difficult COVID patient situations and horrible COVID illness. And then thinking about some therapy groups. Some people have had art therapy and have expressed themselves. And I know there's a session coming next, and there is a certain type of CBT called rumination focused CBT, which completely talks about what is absorbing for you, and the value of the creative side. And there's something called Doctor's Mess, which provides a common room, which is a UK-wide run voluntary basis thing. And they're doing a thing where what is the thing that absorbs you? And I think they use the quote, give the world the best of you instead of what's left of you, which I think a lot of doctors identify with. And the other quote that chimed was somebody saying they love running, they do it on Strava, they do it, love it, enjoyed it, but then they look on Strava and they said something like comparison is the thief of joy. And I just thought that's a pretty good quote, that, you know, we enjoyed the run until we compared it with anyone else's run. So just doing it for the sheer joy of it, but also local offers of peer support or mentoring, coaching, and all those other options. Just in response to somebody's question earlier, what about less travelled career paths? Medic Footprint is on our website too, and that's a good one to look up because it includes aligned medical careers as well as sort of more niche things. And people often like to think of their options, even if they never leave, and sort of, you know, better times come and they work out how to balance their job and their work to enjoy all those aspects that you mentioned earlier during Caroline's talk of what drew you to medicine in the first place, and specifically to your wonderful specialty. So I don't know if there are any questions. I think the next slides are one on my thanks to Simon and everyone at Practitioner Health, and a final one that's just got a few references on it. But I'd be very open to any questions. And I can't see the chat, so that would be great if any of you could share any questions.
So thank you, Claire, so much. That was so lovely to see some of the CBT tips, and I think everyone will take something away from that on different techniques they can use on a day-to-day basis. I just got up quickly to show you my CBT diary. So when we sessions, I draw all of my diagrams. So there's my 5P diagram there. So it can be done, and it's such a nice exercise just to evaluate your life and all the things that, you know, are constantly overwhelming our brain, and we just need to sometimes write it all down. Looking at some questions, let's see, does anyone have any questions? The group have been really great at putting up some resources as you were going, Claire, in the chat so people could access them. Any questions for Claire? Go on,
if no questions are coming yet, and we could leave it another minute or two, I just want to sort of revisit the organisational structure and the importance of organisations taking responsibility for helping to make the job sustainable for everybody, because everybody needs paediatricians, and you know, we know that rotas are something that are a constant part of your lives. And so thinking about these structures that could help support, I heard a lovely story actually, somebody who was redeployed to ICU as a junior, and they said they've put us into small teams. We've got a consultant and 2 juniors. We're staying with each other for 8 weeks. That consultant is going to help us sign off our portfolio requirements. We know where to turn to if we're not happy, or if something's not gone right. And also if there's a complaint or something's not going well, to have a support structure. So I just sort of wanted to reiterate that, because I'm very conscious all my talk has mainly focused on us as individuals. And I think doctors are very resilient, very good at bending backwards and coming back up again. But there comes a point for all of us where it's just one too many things. And COVID's actually often been that straw that breaks the camel's back, things that link to COVID. So just to reiterate, we can do these things individually, and it does lead us to feeling better, but we need the organisational stuff as well.
Absolutely, Claire, and I can't agree with that more. And hopefully this is one of the organisational things that will help. We're from the School of Paediatrics. There are a couple of questions coming through now. So Sarah said, thank you so much for your talk, really excellent. Do you know of any workplaces that routinely offer psychological support to their trainees and staff?
Gosh, that's a really interesting one. I haven't heard of from a paediatric point of view, but I heard a good story in the Midlands where a consultant anaesthetist was taking time to do mindfulness sessions at the end of the nurses' shifts. He was providing them for the nurses, and he was baking on his days off and taking it in. And he'd done one of these first aid courses, where mental first aid, where staff members provide it for other members. So I think that's a nationally organised thing, which may, I think the training's happening now, so that might start to get rolled out more. I think it's quite individual what happens in different workplaces, and some places are more proactive than others. Obviously everybody's overwhelmed from a work point of view, and it's really getting things to marry up, because in the first wave, people felt they were very supported with food offers, and, I think there was a airport style lounge where people could go and sit in relaxing chairs and this sort of thing. But unfortunately, second lockdown and third lockdown, people kind of can't see those happening anymore. And, we need something sustainable. So I think it's quite localised, but maybe that mental first aid. Wellbeing hubs, I think, are coming into play now across the NHS. I think January the 1st was the start date. So I think that's something to watch out for too. Should be available to everyone.
Yeah, definitely have to agree with that sentiment that lots of things are being done locally. And it's really hard to actually gather all of that information, because so many great things probably are being done locally, but because we're not everywhere at once, we can't really pick up on that. Claire, I think Roland's also got a question. He's just turned his camera on, so I'll let him speak.
Go for it.
I think I'm unmuted. Hi, I'm Roland. I'm one of the Surviving and Thriving Committee. That was wonderful. Thanks so much, and is so kind of in line with everything we're doing today. I guess part of mental health is we work we all know that exercising is so important, and we work our body, and that's really important, but there's so much stigma attached to counselling and mental health that we're very scared to even go there. So how do we bring it into the workplace so that it just feels really normal, and that we're all thinking about it like we go to the gym, where we speak to each other and we speak to a counsellor. There's so much stigma. How do we bring that in just to everyday life, everyday training? Should we be all assigned a counsellor, or I don't know? I
think that's such a good point. I know that the Royal College of Psychiatrists tried to address that by having people who had received help themselves, who were willing, have their photo taken, and there was a montage of, this is my story, not for people to give their whole story, but to have their photo, and I've accessed help and it's been good for me. And I have had a number of people in different roles who are willing to tell their trainees, I'm a consultant, I've accessed help, it helped me. there's nothing that anybody need, you know, we all need help sometimes, especially in these completely unprecedented times. But something I found really helpful is we ran some doctors' common rooms, we called them, and this doctor's mess idea. I think normalising the feelings that we're going through, and I've heard several of them expressed during Caroline's talk and through the questions people have been asking, and also your cases where you've got real people, paediatricians in training, giving their own experiences. I think that's so powerful, because I think we often want to identify with somebody. I'm a bit like them. That happened to me. How could I manage it myself? So I think the more sharing that happens like that. So in the common rooms, ours are on an events page in PH, and there's a culturally diverse common room. In Doctors Mess, it's a different organisation, but they're focusing on, you know, what do we enjoy doing that absorbs us is their current topic, and I think they've got one tonight. So I think it's people being willing to speak up, and us treating it like supervision. So I have CBT supervision once a month because I provide some CBT, and it's a place to store my, you know, questions or concerns, knowing I've got a safe place to take it, just like clinical supervision. So I think it's a great question, room for us all to keep developing that.
Thanks, Roland. And I have to completely agree with that, Claire. And it's all about showing that we are not alone, and actually everyone has these difficulties and things that they're going through, and actually normalizing them and coming forward and sharing our stories, or just being part of this group today. It's all about that, which is actually this is completely normal. I know that previously I've needed to have mental health days, but been too scared to take a mental health day, to just be like, guys, I cannot physically come into work today because I'm not in the right headspace. But having that fear to speak up, to say that, and actually empowering us with days like this to say it's normal for us to feel like this, and you know, have that energy to say that. So I don't think there are any other questions, Claire, but thank you so much. Some really great techniques that we can hopefully take forward, and really thinking about like changing our way of thinking to, I'm going to stay in bed all day, to actually let me put a plan in. What is my plan for the day? All I have to do is. Really great things. I really like the virtual flower as well, and I'm sure people will take the visual flower, and I'm sure people will take that on board as well. So thank you so much, Claire, for your time.
You're welcome. Thank you for having me. And good luck to you all.
Thank you so much.
You're doing such an important job. Very grateful.
Thank you so much, Claire. So now, tying in very nicely, we've got one of our trainees, who Sarah's going to talk quickly about her experience.
So, hi everyone, my name is Sarah. I am a Peds Reg. I'm currently working in the community, but working in West London. Thank you so much for asking me to talk today. I've been asked to talk about my experiences of being a trainee with health problems, and also a bit about being a trainee during pregnancy. So to give you a bit of background about myself, I've got rheumatoid arthritis. I was diagnosed when I was about 19, so have dealt with it through most of medical school and then through all of my training, and have had various ups and downs in terms of issues with pain, issues with mobility, issues with manual dexterity, which has been an issue on neonates, for example. And I'm generally in a really good place at the moment, but just wanted to share my experiences with you about some of the challenges that I've had and how I've overcome them. And I suppose really taking on the theme of today, how I've survived the problems and then how I have thrived. And I think, as we've been talking about, and as Nisha's just said, what I really wanted to just really highlight, if nothing else, is that just to take home that you're not alone. We all have something. Everyone struggles with something at some point or other during their training. What I'm going to talk about are the things that have helped me. They're my experiences. Some of it may resonate with some of you, some of it may not. But these are the things that have helped me, and I hope that something that I say might be helpful to someone out there who's listening. So just taking on that theme, in terms of the things that have helped me to survive, as it were, having a health problem during training, I've always found it really useful to be very open with people about what my problem is. and how it might affect me. So I always speak to occupational health if I can before I start, but that's not always possible, if not quite early on in my post, to discuss what my issues are, how it's affected me in the past, and whether any changes might be necessary, and if so, what. And I also talked to my educational supervisor about it really early on, so that, again, that they're aware. And I've always found that people are incredibly understanding and supportive and really want to help to make things as easy as possible. And I tell my colleagues as well, particularly people who I'm going to be working with, especially on call shifts, where potentially if I start having a flare up in the middle of a shift, which has happened and is a bit of a nightmare, that they know what's going on and they can be helpful and we can kind of work through it together. So just talking to people and telling them what I'm going through, I found really helpful. I appreciate that some people might not want to do that and might not feel comfortable doing that, but I have found it a really useful thing to do. It's worth being aware that depending on what problems you may face, there may be some reasonable adjustments that can be undertaken to your rota or to your workplace, and that's worth discussing with occupational health as well. And sometimes having a union involved can be useful to support you through that too. And there are loads of services and organisations and people out there who can support you through these things. We've obviously just heard from Claire and Practitioner Health. The PSU is also, Professional Support Unit is also a really good resource. And then obviously having support from my specialist. So my rheumatologist has been brilliant throughout, and my GP has also been brilliant to help me in terms of the support that I need, but also just being able to get myself to my appointments, having the blood test that I need for the medication I take, and managing all of that around work and training, and also having a child, which is what I'm going to talk to you about pregnancy in a minute. In terms of thriving, so I think the things to me that have been really important, that I think echo what's been said already today, is around prioritising my health and my well-being. So I make sure that I have a little bit of time to myself. If I'm having a bad day, if I'm in a lot of pain, or if I'm feeling really stiff, or if I'm just feeling really frustrated because I've fluffed another cannula in a small baby because my swollen fingers don't really let me do very much, and I'm just feeling a bit fed up about it, then I just really make sure that I take a bit of time for myself to have a little bit of headspace and kind of process that. I like doing some things to sort of unwind. I like to bake. I'm not very good at it, but I enjoy it, so I do it. And talk to my family with that, and going for long walks and things, and taking a toddler to a playground is always quite nice activity to do. But the other thing that I always try to do is I try to take a little kind of smattering of days of annual leave, not like not as a block of leave to go on holiday whenever we're able to do that again, but just the odd day here and there when my husband's at work and my toddler's at nursery and I make no plans, so I know there's no one at home and I can do whatever I want to do, whether that's spend a whole day in my pajamas watching Disney, which I enjoy doing, or whether it's doing something a bit more productive, whatever it is, I make sure that I take that time for myself, and that's always been a really helpful thing for me to do. And then making use of my support network. So my family, my work friends, my home friends have all been a huge support, and have helped me through some of the more difficult times. The other thing I just wanted to touch on really briefly is how it's affected me during COVID. And I don't want to talk about it too much, but just to say, and I know that I'm not alone in feeling this way, that because of the medication I take, I am vulnerable. And from April until September, I was completely non-patient facing. And then since September, I have been patient facing, but only in the green zone. And actually, I'm in the community at the moment, which works pretty well. And I have struggled with enormous feelings of guilt about not being on the front line, working with my colleagues, fighting COVID, looking after adults. And I know I'm not alone in feeling that way. And the way that I've kind of come to terms with that and rationalized that is really trying to put on that positive spin of whatever work I'm doing, even if I'm not looking after people with COVID, the work that I'm doing still needs to be done by somebody. And if I can do it, that is still freeing up other people to be able to go and do the stuff that I can't do. We're all part of the wheel, and that's really, really helped me to come to terms with that. So I just wanted to kind of chuck that in there in case that resonates with somebody, because I know from various forums that I'm on that a lot of people who are not patient facing or shielding or working from home are really struggling with that sense of guilt. And I don't want to say that it's completely gone away. I still feel it sometimes, but it's been made a lot easier by trying to think about it in that way. Pregnancy is the other thing that Nisha asked me to talk about quickly, and I thought I would just kind of rattle through that a little bit, because everyone has such a different experience of pregnancy, and it depends on how you're finding it, what pregnancy-related symptoms you may be having. The things that I found really useful and important were getting help, again, from occupational health really early on. And I approached them very early on, really because of my arthritis, but actually they were brilliant in terms of allowing me to say what I felt comfortable and able to do, and supporting me with when it felt appropriate to come off the on-call rota or stop doing nights, and to change the way I was working a bit. So approaching occupational health early was useful. And just to highlight that for pregnancy, you are entitled to reasonable time off to attend your appointments. Obviously, it helps your team, and if it works for you and you can, it's useful to try to take those appointments in your own time. But you are absolutely entitled to that time to attend those appointments. And if you need to do that, that's absolutely your right. And you should never be made to feel bad for attending those. And then just things about knowing your pay entitlement, knowing your leave entitlement, knowing about things like kit days, which can really help. The things that I found really useful to help me really thrive throughout my pregnancy and maternity were, firstly, naps. Naps were brilliant. If it's a pregnancy after your first one, if it's second or a third, naps might be a bit more challenging if you've got toddlers running around. But naps were vital for me in my first pregnancy. Taking a bit of time to really just focus on the fact that I was pregnant and a person and a human beyond just doing my job was really important. So I did NCT, which was great, and met some lovely people, but also I did some antenatal yoga, which was really nice just to have a little bit of time just for myself and my pregnancy. And then I found a few sort of buddies, for want of a better word. So trainees who were pregnant or were on mat leave or who were already less than full time for childcare reasons. And that was really useful in terms of navigating all the complications of how to do your less than full time rota and how to sort out your mat pay and evening out your pay over the year so that you don't get loads of money, not loads, but you get your money at the beginning and none at the end. And then being aware of the resources that were available. So the Return to Acute Clinical Practice course and mentoring, and all the support and funding from HEE. So just knowing what was out there was really helpful for me. I'm going to stop talking because I think I've been talking for long enough. I just wanted to just say, I suppose, take home for me, you're not alone. We all struggle with something. Whatever it is, whenever it is, at some point in our training, everybody struggles, and that's okay. And it's about knowing what is available and what support there is. But take that support. Don't be afraid to look for it and ask for it and take it, and take a little bit of time for yourself. I don't know if anyone's got any questions. I can't see anything on the chat, but I'm really happy to take questions either now or I can give out my email address, and I'm really happy for people to get in touch with me later on. I hope that's useful for somebody.
Thank you so much, Sarah. That was incredibly useful. Just whilst we let people add any questions to the chat, I just want to say, on behalf of our Surviving and Thriving subgroup, the Day and the London School of Peds, thank you so much for sharing your story, just breaking it down, the steps that you took. There was something in there for everybody, whether you've been through pregnancy, whether you've got kids, whether you've had a medical condition. There was definitely lots of things there that I took home from that, and I'm sure lots of people would say the same. And also, I really appreciate that you touched on your feelings about being non-patient facing and shielding. And again, I'd like to reiterate what Sarah said, that I'm sure all of us, whether we're patient facing or not, have all at some point, maybe because we're not in the adult COVID world, have felt that guilt at some point. I know I definitely have, and it's been quite difficult hearing from other adult medical colleagues about their experiences, and worrying that you're not able to provide them with the same support that they may get from others who are going through it with them. But Sarah, honestly, that was really, really helpful. Thank you so much.
Really pleased, thank you.
And we really appreciate it.
I'll put my email address in the chat, so if anyone does want to get in touch, please do. I'm really happy anytime. If I can, if I can do anything to be useful, then I'd be thrilled.
Thank you so much. So I don't think we have any questions. And I did see Heidi in the chat before, and I saw her face pop up. I'm hoping she's still here.
Yep, I'm
Lovely.
still here.
Great. So we'll now go on to our next talk, which is from Dr. Heidi Edmundson. So I'm so excited about this session. I don't know if any of you were able to attend the LSP conference, but she also did a session for us then. Heidi has worked for the NHS for over 20 years. She's a consultant in emergency medicine at the Whittington, and in particular, she's really passionate about using creativity to facilitate staff wellness, empathy, team building, and empowerment. She's run various initiatives involving drawing, creative writing, theatre techniques, and many of which that draw on forum theatre developed by Augustus Boll. She's currently active in setting up an arts committee within her hospital and believes strongly that by engaging in creative tasks, people can express their whole selves and connect with the humanity in themselves and in each other. Thank you so much, Heidi, again for joining us today. And for anyone that's on Twitter, just quickly, I'll mention her Twitter handle, which is @Heidi_ED. Over to you, Heidi. Thank you very much.
Hi, lovely, and thank you for asking me. What I plan to do in this session is I've got a very brief talk to set the scene, which I will hopefully share with you to begin with, and then I will get you to do some drawing, and hopefully you can learn a couple of exercises. Just get confident in doing it that you can take back to your own departments. Apologies if there's anybody in the audience who's heard some of this before, seen bits of this presentation before. Paediatrics have always been very good to me and have asked me to speak at various things, so I might be a familiar face to some of you. So first of all, let me see if I can try and share my talk, which is the bit I hate because I never can do it. So we'll just give it a go and see what will happen now. Can you see that?
Not yet, Heidi.
Right, I don't know what is right. Let me see. So if I press share.
Yeah, if you click on share, make sure your slides are open in the background. If it's minimized, it won't open.
Let me see. No. Is that, can you see that now?
Not yet. So if your slides are open in the background, then if you unclick share and then click it again, it will sort of refresh it and then it will come up again. If not, I think both me and
Let
Ciara.
me see. Maybe is this it? I'm pressing share now, so maybe this will work.
And then options on the bottom for which screen you want to share.
Let me go right. So if I click, if I don't, I can just do it without the slides. But if I click share content,
yep, and
then I should see surviving and thriving. If I click on that, no.
Oh, hold on, maybe. Yeah.
Yes. Perfect.
Yeah. Right, great. I don't know. I have nightmares about this, but anyway, this is a brief talk at the beginning and then we'll have time afterwards to do some drawing. So really, I just think it's good to give some context about why I am doing this. So really, it sounds, particularly in the middle of the pandemic, why are fun and creativity important? Well, fun and creativity are important for a variety of reasons. And that is, if you are engrossed in fun or creative tasks, they take you to one place, and that's the present. And as paediatricians, you probably are better at this, knowing this, than people who do adult medicine, because actually children are very good at this. You can watch children and you give them a little bit of fun or a little bit of a box with a few bricks in it, they will become absorbed in their own world and they'll be completely and utterly in the present. And being in the present is a very healthy place to be, because when you're in the present, you're not fretting about the past or worrying about the future. And this is really what mindfulness is. And the NHS endorses mindfulness. You can have apps. Some people, mindfulness suits very, very well, but actually there's a lot of people that find mindfulness difficult, but actually fun and creativity work the same way as mindfulness. Fun and creativity, quite often, both of them will let you laugh, and laughing is incredibly healthy. And actually, laughter yoga just gets you to laugh even if you don't feel like laughing, because that's one of the sort of paradoxes of laughter. The times you probably could most benefit from laughing are the times you most are least likely to do it. But actually, when they laugh, it's now quite well known, you will reduce cortisol production, you'll reduce your blood pressure, and you will also increase oxytocin and serotonin production, and you will increase your pain threshold. So there's lots and lots of studies have been done about the benefits of laughing. Also, if you laugh together, it will inhibit your fight or flight response. So laughing actually does reduce stress from that point of view. And quite significantly in our job, if you laugh together, if a group of people laugh together, they're more likely to bond together. And teams that laugh together will bond together. And they've done quite a lot of studies on a variety of creatures like monkeys and parrots, and they all laugh. And it's not to do with humour or jokes, it's to do in a way with a kind of, it's a bonding activity, and there's a lot of anthropological studies on this. So teams that laugh together will bond together. Creativity has also been shown to increase positive feelings. And there was recently, I think it was at the end of last year, the WHO have done a whole meta-analysis on the arts and how it affects both physical and mental health. And they've looked at all the studies, and they've definitely been shown that the use of creativity, the use of any of these kind of artistic pursuits, whether it be drawing, singing, music, people who engage in those, that will increase their positive feelings. It also increases feelings of empathy, which might be one of the reasons it increases positive feelings, but it's certainly quite important. And certainly when we look at social prescribing for the community, it's this whole idea to bring creativity into it, give people creative tasks. So again, it's something to look at for the world of actual sort of medical professionals. There's something about drawing as well, though, that if you actually get people to draw, it sometimes makes it's easier for some people to express things that are difficult to say. So if you just get people to draw, it's actually easier than actually coming out and saying the things. And that's quite a healthy thing as well. Interestingly, if you add a bit of fun to something, people are more likely to change their behaviour. And this is called fun theory. And the reason it's been used in quite a lot of public health campaigns, but one of the most famous was in Sweden on the underground, where they wanted people to use the stairs and not the escalator. And of course, people didn't want to use the stairs. People just use the escalator all the time. So they changed the stairs into a giant grand piano, and stair usage went up by 66%. So if you want to try and change behaviour, instead of telling people to change their behaviour, actually try to introduce fun ways to get people to change their behaviour. I think, though, if we move back into this concept of creativity, when you say you want to do something creative, you'll get one of two responses. There'll be a group of people who'll be delighted, and there'll be a group of people who'll be absolutely and utterly horrified. And that reason is this comes from a whole lot of conditioning through our youth, through our childhood. And for people who are horrified and don't think of themselves as creative, they actually can have some quite interesting ideas about creativity, because there's a lot of people who'll say, well, I'm just not creative, and they'll think people are just born creative. That's all it is. You can be born creative, and then you're born a creative baby and you become a creative person. And more significantly, they think that creative people just wake up in the morning and think, right, I'm off to be creative now. I don't know, Leonardo just got up and decided, I'll just paint the Mona Lisa. Let's Michelangelo thought, let me decorate that ceiling of the Sistine Chapel. That's how creative people are. They're just creative. It's always there. It's always switched on. But actually, if you speak to anybody that's creative, they'll tell you a very different story. And what they will tell you is that for creativity, it requires two things. You have to follow a process and you have to end up with a product. And first of all, this idea of a product is quite interesting because people, quite often think creativity is a bit airy-fairy. But if you think about it, actually, creativity produces things that you can quite often are very tangible. You can look at them, you can hold them, you can feel them. During the pandemic, you might have thought creativity wasn't much use, but a lot of us got through by binging on Netflix, which was all sort of products of other people's creativity. So it produces a product. But what is also very, very interesting is creativity. It's this process, and there is a process that creative people use to let them be creative. And the reason why this is important is creative people will say this process is to a degree teachable and it's replicable. They will be able to describe to you exactly what to do to get them to be creative. And this is actually very helpful in the world of the NHS, because actually this process touches on quite a lot of things we talk about wanting to be better at and do more at and that are healthy for us. So innovative thinking, that's actually the same process as the creative process. Complex problem solving. There's a lot about complex problems now, and the idea that many of our problems that beset us in life are complex, not simple. And the way to solve these is very similar to a creative kind of process. Compassionate leadership and listening with fascination, that comes up a lot. It comes up with the kind of leaderships, the kind of leaders we need to be. And again, this is much more a kind of process, and creativity fits very, very well into listening to people, engaging with people, really finding common ground to meet them. Again, to do with looking at things in a different way. I've caught the previous speaker, but a lot of it is just finding a way to reframe things, look at it differently, take what you've got and twist it round and look at it. And reforming problems. And listening to hear, not answer. So all of these kind of ways of the process of creativity, if actually we spent a little more time doing it, it would be quite helpful to the NHS. Another thing about creativity that's quite important is this idea, a lot of creative people will tell you it's about finding the story in something. And if you think about it, most creative objects, most things that have been produced by creativity, there will be a story there. So sometimes it's obvious in that it is a story, other times, but even things like paintings, pictures, songs, there is a story behind them. They're a way of reproducing a story. And as human beings, we respond incredibly well to stories. It's something very fundamental to us. Probably one of the earliest kind of things we've got that mankind have left us is cave paintings. And I think they sort of represent that people were telling stories right from the beginning of time. I don't know if anybody saw this. There was something in the paper recently that they've discovered cave paintings in Indonesia of a big pig and some other animals, and they are 45,000 years old. And they can tell by the way those creatures are arranged. This isn't just a replication of what is happening. It's some kind of internal world as well it's representing. And that shows that that's a story, that people were telling each other stories 45,000 years ago. And that just really is a huge amount of time. But this is important for us in our well-being with the story, because again, this is what a lot of people will do, that trying to find the story behind something is quite a helpful thing to do. It's what connects us to our core values. It reminds us why we're at work, what we came into the job to do. And it's particularly good to be able to find stories and things, particularly at this time, because it helps us find meaning and make sense of what we've been doing. And a lot of times that's what people will do, or people need to do, to get through times that are stressful and difficult. We have to remind ourselves of why we're doing and what the story behind it is, and to make sense of it. Understanding stories is also very important to do with understanding culture. And we talk about, what's the culture of your organisation, what's the culture of your department. And again, that's something, a phrase that we will use, but it's very difficult to define. And there's lots of difficult ways of defining it. But one way to saying culture, it's not just some cloud that hangs over us that we don't interact with, we don't engage with, we don't take part in it. And some people would say culture is the stories that we tell each other. And the reason for that is because there are myths and legends. So you all know that you will go to departments that you will be told are good departments, that have a good history of teaching, and we tell each other stories about places, and that affects how we feel in them and how we see them. Certainly creativity is important because it gives you a voice. And again, this is quite important at this time, and this time where we're all struggling, we're all finding things difficult, because quite often you can talk to people and say, we'll do a bit more creativity, we'll do some of things like this, and people will say, we don't need creativity to make us happy, we just want better rotas, we want better work conditions. I'm not disputing that everybody does want better conditions, but still there is something that is to be said about having creativity. And the reason for that is creativity, also having a creative voice, is sometimes the only voice you have, and creativity in some ways is an act of rebellion. So if you're somewhere and you want to change it, sometimes you have to start somewhere. You can't sort of manifest sort of widespread change quickly, and somehow there's something about having that creative voice that allows you to express yourself and start the process of change. There's quite a lot about this coming out now, and it's this question to ask yourselves: what are we, and what are we in the workplace? Are we human beings, or are we human doings? And I think this is probably another of the reasons why people are becoming sad, disillusioned, upset at work, because if you just think of yourself as a human doing, that is, you're just a person who performs the functions of your job, that actually becomes quite a dispiriting place to be. And there's quite a lot will now come out of this. Is your organisation or is your work transactional, or is it relational? And a lot, we've got into a workplace that's very transactional. It's all about targets, it's all about performance, it's all about things like that. And quite a lot of companies post the COVID pandemic are saying they also need some measurements which are more relational. And they're things like asking how much people are thankful in their workplace, how helpful people are to each other, how caring people are. These are measures to make us more care about the relationships we have. And the final one is how fun is somewhere to work. So these are becoming more and more important to keep us going. And again, this fits in with this idea of fun and creativity. And the problem is if we only see each other as human doings, and we come into work and all we start to see each other, ourselves as, and the people we work with as, people who perform the functions of their job, it's like looking at them through the wrong end of the telescope, and that diminishes them. You diminish each other if all you see them as a person who performs a job, rather than a whole person with all these other aspects to their personality. So I've told you why I think people should draw. So why aren't we all going into work and drawing? That's very, why don't we all just go and do it? Well, we all go in and we're all working in the middle of a pandemic, and saying, let's take 10 minutes to draw together as a team. It seems almost laughably small, a teeny tiny little thing. And we feel we're like this at the moment. We're about to be swept away by this huge big wave. And I'm saying, why don't we just go in and draw? That's the answer to our problems. But again, remember, mighty oaks from little acorns grow. Getting people to just spend a small period of time doing something different can actually have quite a powerful impact. And again, we go back to what's culture. Remember, it's not a big cloud that hangs over us. Some people might say culture is a bit like a garden, and you need to keep on cultivating it, working at it, and doing lots of little things like that. Some people are scared of drawing. And the answer, why is this? Well, there's lots of reasons why people are scared of drawing. It puts some people out of their comfort zone. But then we should say, why should we draw? And the reason why we should draw is if we're put out of comfort zone, particularly if you get lots of people to do it together, it flattens hierarchies. And this leads to this organisation that's much more psychological safety. So if people spend a little bit of time doing something that's slightly different for all of them, that will get their interactions being a little bit different. Other reasons people are scared of drawing is people are just scared people are going to laugh at them, trying to do anything different, trying to do anything creative. People think they're just going to be teased, they're going to be laughed at. There's this kind of fear. But really, again, go back to this idea of people who spend their life doing a lot of creativity and can teach creativity, they will tell you to stop thinking. Thinking kills creativity. So they have much more of an approach of just do things, don't think about it, nobody's going to laugh at you, because actually the person that's probably going to ridicule and laugh at you the most is yourself. And it's quite good to be caught up in something that just tells you, look, stop that judgment, stop judging yourself. And the less judgmental you are to yourself, probably the less judgmental you'll start to be to others. So it increases this kind of a much more healthy kind of environment to be in. Other reasons are people just think drawing's childish, it's a bit silly, we're all quite serious, people don't like to look childish, but actually what it is, it's playful. And there's a certain thing about playfulness as a good place to be in. Playfulness is a very good place. It allows us to grow, it allows us to develop. Again, if you think of all the way playfulness allows children to develop, and actually that doesn't stop us when we're adults. Finally, people say we just don't have time for this. We're in the middle of a pandemic, we're short-staffed, it's ridiculous, we don't have time for it. I would probably say we don't not have time for it. We're in the middle of a pandemic, we're short-staffed, we're desperate times, we need to start doing something. So really, those are my reasons why we should draw. And now, in the remaining time that we have, I think we should all do a bit of drawing. So can I ask, can everybody get themselves a pen and paper? Right, I see that you've got a pen and paper. So if everybody wants to get themselves a pen and paper, we've got a little bit of time to do this. So first of all, what I'd like you to do is start off by at the top of your pen and paper, just give yourself a number. Don't overthink it, how you're feeling out of 10. I'm about, I don't know, I'm about a 7. I find this a bit nerve-wracking, but I've got a bit over with. So give yourself a number and then give yourself a colour, how you feel out of 10. So if you were a colour today, just give yourself a write down what colour that would be. If you've got any coloured pens handy, you might want to choose that as your colour. Now, the next thing to do to get everybody warmed into this is start off and draw something nice and simple. Again, some of you will enjoy this, some of you will be horrified. As I'm from the Whittington, I always tell you to draw a cat. So draw a cat for me. Any way you want to draw a cat, just draw the cat. Now what you can do is, if you've drawn the cat, put your pen in your other hand. I imagine everybody will have drawn it with their dominant hand. So put it in the non-dominant hand and draw another cat in your non-dominant hand. You can do the same cat, you can do a different cat. It doesn't really matter. Just try and draw another cat in your non-dominant hand. Right, if you've done that, then close your eyes and draw the cat. Try to draw the cat somewhere in the paper with your eyes closed. Now look at all those 3 drawings and just compare them. And what a lot of people find is that as they move through them, particularly the drawing with the non-dominant hand, quite often seems to have a lot more character to it than the drawing with the dominant hand. It's the one that's connecting up to the more creative side of your brain. It's the one where maybe you just decide it's going to be crap anyway, so you stop judging yourself and you're willing to pour a lot more into it. It's a bit quirkier, it's a bit more lifelike, it looks a bit more fun. And then if you look at the one with your eyes closed, you can tell yourself that it looks like something Picasso will have drawn. It's just crazy, it's surreal, it's bizarre, but it doesn't really matter. And then that's it, again, it reflects something of your personality. So if everybody, and I don't mind if people know a way of sharing their drawings, they can find ways of sharing their drawings in chat if they want to share them. So the second thing I'd like everybody to do now is I just want you to think of the first thing that comes into your head and then try to draw it. Again, don't judge it, don't censor it. Even if it's something very rude, you're probably in the privacy of your own home, so nobody's going to care what you are drawing. Even if it's something you might find it a strange thing you've thought of, you might find it a bizarre thing that this is the first thing. Sometimes people freeze when they're asked for the first thing that comes into their head and can't think of anything in the whole world. But just think of something and then try to draw it. And even if you can't draw it, don't worry, just try to draw it. It doesn't really matter. In our lives, where we're constantly under pressure to get things right and to do things well, this does not matter. It's a game, it's fun, you can be wrong, you can be bad, you can be not very good. None of these things really, really matter. You might be surprised by the first time thing that comes into your head. As I say, it can be anything that you want it to be. Now, draw that thing again and draw it with your non-dominant hand. And then finally, draw it with your eyes closed. So next, take again a few moments, look at your drawings, be amused by them, find them a bit entertaining, look and see what look to see how the one with the non-dominant hand, see if they're moving along, see if you feel more confident drawing, if you don't like drawing, any of those things. So the next thing I want you to do is, if you take a few moments, then draw me something, and draw something to represent how you feel at this precise moment in time. Now, don't overthink this. Some of you might be able to draw how you feel quite well. If others don't overthink it. This is not an intellectual exercise. You might be surprised. You might just draw something that you think is easy. It can be abstract. It can be a shape. You might just want to do a big scribble on the page. That might be the way you feel. Just draw how you feel, and take something and take a little bit of time to just draw something and look at it and see how you feel at this moment. And again, you might be surprised by what you've chosen to draw. So just think a little bit about what it is and how it's affected you and anything like that. Then swap your hand around and again do it with your left hand, and again try to draw with your left hand and see how that makes you draw how you feel at the moment with your left hand. And finally draw it with your eyes closed. And again, just take a few moments to look at the different things you've drawn, think a little bit about them, think a little bit about how you're feeling. Now, if you want to draw something that makes you happy. Can be anything. It can just be something like to do. It can be a dog. It can be an abstract thing. If you can't think you can draw what makes you happy, just do anything that represents happiness to you, but draw it and see how it makes you feel. Then draw it with your left hand. And look and compare the two of them. And finally draw it with your eyes closed. And last of all, draw a picture. If you could give yourself a big present at the moment, draw what you would like to give yourself as a present. And it can again be, you can be, if you want to, you might want to be literal and just draw yourself a piece of cake or a glass of wine or something like that. But even if you live in a tiny flat and you want a horse, draw yourself a horse. But just think what you would like. You can have it something abstract like world peace, the end of COVID. I suspect might be in many people's minds, but just draw yourself anything you would like and just see how that makes you feel. Then draw it with your left hand. And then draw it with your eyes closed. And then just take a few moments to look at all your drawings, see what they look like, see if there's anything that surprises you, if anything makes you laugh, anything you think's a bit strange, anything that's a bit funny. And then what you can do is you can just think for a few moments again, if you want at the end to think of a number you're feeling out of 10 and assign that number to yourself, and you can assign a colour to yourself. See if it's the same, it might be the same, it might be different. And basically, this is a sort of just a little exercise, but it's in a way, it's something you can do. We do it in sort of, if you have a teaching session, it's one of the ones that we do in one of our teaching sessions together. It generates a little bit of conversation around wellness. It can generate conversation about how people are feeling. It's easier to get people to discuss and open up about how they're feeling. It's a more democratic way, in a way, instead of just saying to everybody, how are you feeling? If you ask people to draw how they feel, get them to comment on it if they want, get them to discuss it if they want. If you want, sometimes you can get them to hold their picture up and let other people guess how they're feeling. So there's different places you can go to it. So really, it's a very simple exercise that you can do really in a kind of teaching time you have, if you want to use it a little bit differently to discuss well-being, to give people something else different. You know, if you buy a lot of felt tips and coloured paper, everybody gets excited. You can buy glitter and things. Even adults get very excited at the sight of glitter and stickers. It's not just children. So really, as I say, you can do it in with your teams, you can do it in small groups. It's just a way, sometimes in the evening, if you want to come home and you want to do it, it's sometimes quite a good way to doodle out how you feel as well. Don't know, has anybody any questions you want to ask or anything? I've got a few, about 10 minutes left to take questions. If not, everybody can get themselves a drink.
I've got a question. How do you find day-to-day incorporate it?
How did I find day-to-day? It was, what I did was, and how I started to incorporate it was, I realized that if you want to try and bring wellness into the day-to-day workplace, you're going to struggle to get extra time for it because nobody's got any time. So actually the way I started to incorporate it is we had teaching, the way we do our teaching, we'd moved to doing 10 minutes of teaching a day, which we called 10 at 10, very cleverly. And you know, we had a slot every day, so I just took a slot and I just took them for, I said I would do wellness. And to begin with, I talked a bit about wellness, but then I wanted to make it a more interactive kind of thing. And during that time, pre-pandemic, I played a lot of games, but then post-pandemic, when we were in the sort of the midst of the pandemic, I couldn't play games. So what I had, because of sort of social distancing, well, I used drawing beforehand as well. And then post-pandemic, I did more drawing and did more like that. So I think it's probably, I think you need to find very bite-sized ways to introduce it into whatever you are doing. I think, you know, from our morning handover, you know, after the night shift, we quite often get people, you know, even, you know, you could get people to just draw one shape as how they felt at the end of the night shift, you know, say something positive about the night shift and draw a shape. I think it's all, you have to see what time you have and time you have when you're interacting, and try to find ways of promoting maybe more looking at your feelings, etc., that are beyond just saying, okay, how does everybody feel? Because that sometimes is a difficult place to go to. So I think that would, I'd recommend adding it into the workday.
Does anyone else have any questions? No?
No.
So I have a quick question, Heidi. I was just wondering, when did you discover that you could draw?
Well, actually, I discovered, this is quite interesting. So I first, about 2 years ago, I had to present a talk on the wellness stuff that I was doing. And I came upon the idea of getting all the people in the department to draw me a picture for each of my slides. And I went round and I got everybody to draw, and I wrote the presentation, and I then got everybody to draw. And this is about 2 years ago. And then somebody said, oh, haven't you done a drawing? And I said, no, I don't draw. And then as I said that, I thought, I can see the real hypocrisy of this one, because I'm telling them to draw and not to worry, and I don't care what it looks like. And I actually realised I didn't want to do it myself. So then I drew a picture for the talk. I thought it is important. So I drew a picture, and then I had another talk to do about something unrelated to wellness. But I thought, actually, I might... I thought of it, I thought, actually, I'm going to draw my own slides as well. So I started to draw, and then the more I began to draw, the more I just got to do it. And I've actually got a series of about 10 cases as well that I use in teaching, that I've drawn out like a cartoon strip as well, to make them more interesting, rather than just presenting complaint patient presented department with sore leg. So I actually have only discovered it. I don't even know if I would necessarily can draw, but I've endeavoured a love of it, and I find it very relaxing. And I found it incredibly relaxing during it is my lockdown activity. You know, the way we've all got a lockdown activity. It's one of my lockdown activities.
And that was probably my next follow-on question, which was, when do you decide that you can draw? I think personally, I would say it's when somebody else can decipher what I've drawn and tell me back what I've drawn and it's accurate. Would you agree?
Yeah, or I think it's just when you actually, I think a lot of it is when you have the confidence to do it. If you decide, you know, if you'd have told me you'll draw all your slides for a presentation 3 years ago, I'd have thought of you gone completely and utterly insane. But actually, once you start to do it, and it's quite funny, it's why it's a good idea to do it and look at it, because I think once you start, and I realise you draw very small, and it's very light. People who don't like doing it's very small because you're scared to put your pen and pencil to the paper. And that's why you think about it, you're terrified. And then actually, as you start to do it more, you become bigger and bolder, and become bigger and bolder like that. So I think it's probably, when do you decide you can draw? I don't know. It's maybe a bit like, once I remember years ago when I was still a registrar, somebody asked me when I felt that I was a proper registrar, and I remember one of the answers we were talking about it was, when I'm not scared to come in and do the night shift on my own. So I think maybe you can decide you can do anything. You're not scared to have to do it, would be my answer.
Definitely. Thank you so much for that, Heidi. I really enjoyed that task personally, and I just wanted to touch on a few things that you mentioned during your presentation. I think, first of all, it was really refreshing to see a non-typed PowerPoint presentation just filled with drawing and handwritten scripts, which was fantastic. And I just really liked the way you touched on playfulness, because I think, I don't know if I speak for everyone, but part of paediatrics is, you know, bringing out the child in you. And I think that's what we achieve when we draw. And ultimately, it is really fun. And also your comment about being human beings rather than human doings. I think that's a really strong concept. So thank you very much for taking the time to spend with us today. And we do hope you'll be able to join us again.
No, it was lovely. And it's interesting you said about paediatrics. I think, you know, I've always found paediatrics one of the first audiences I had discussing this, and I found you much easier even at times than my own tribe of emergency medicine often looked at me as if they wanted to punch me sometimes when I started this, but then they all came round to it. But I've always loved speaking to paediatricians, because I think you get that aspect of finding the inner child in yourself, how important it is. So thank you, and it was lovely. Thank you.
Thank you very much.
Sue has many hats. She's a general paediatrician at Barnet Hospital, and she's also DME at that hospital. She's a TPD, and she's integral to the Surviving and Thriving team. So that's all of our team in the LSP. She's been also involved in Child Bereavement UK from the very beginning, and I think she's going to talk about that. That's the main thing to talk about, which is why it links so nicely with Adib's talk. And she's also an associate director of Noah's Ark Hospice, and has written books on parenting and premature babies. The list is absolutely endless, and she's totally inspirational. So I hope you enjoy her talk. So take it away.
Thank you very much, Roland. Thank you. And you've positioned us really well together. Adib first and then me. Brilliant, Adib. That was so good. Adib also very bravely came with me to the Royal College and did an interview with me on the stage, like a sort of a model interview about how to talk to a trainee. I don't know if he felt it was a model interview, but he was like incredibly open. And
no, it was perfect. It was a model interview.
And it was for college tutors across the UK, but also Adib helps me with child bereavement training. And one of the things that I'm really sad about at the moment is that, you know, due to COVID, we haven't delivered any, and we used to deliver 4 sessions a year to 20 trainees. So we get through 80 of you registrars every year. And I'm very aware that we're missing that. And I'm trying to think of ways, Najet and I are trying to think of ways of putting that back on again in a virtual way. But it makes me, I feel nervous about exposing a parent sort of you know, in their own house without me being there, but we may have to do it. So what I thought I would do today is just give you a little feel for some of the important factors around the time of a child's death, really, to help not just the family, but also yourselves. And just listening to Adib, I mean, the bottom line is, there are several messages really. One is, it's all about communication and connection. If you've got those things in place and time, you were a long way towards not only supporting a family well, but yourself. And the other thing I want to say is that you do not cry other people's tears, you cry your own. And therefore, there will be situations when there is, you know, if you can call it that, there's a good death, you know the family really well, a child dies, you feel you've done everything you possibly can, and you might cry with them, but you might actually find yourself completely dry-eyed. And there'll be another situation where you cannot control yourself with grief. And it's always something to do with yourself and how you relate to that situation. So I'm now going to bravely share my screen. And I'm going to include computer sound, and I'm going to share my desktop, which is here, screen 1, but that's not my screen. Here we go. And it's here. And it's now, can you see my desktop?
Yeah, that's perfect.
Yes, yes.
Well done.
If I achieve nothing else now, I'm very, very happy. So I've given you the first slide. I mean, I've used some of my child bereavement slides as a kind of background. I may or may not stick to them because I am sort of notorious for not sticking to slides. This is what I want to think about: how to support families well and how to support ourselves. And I think the important thing is that I'm going to bring up a few cases, situations that I've been in personally, to talk about how they affected me. And therefore, it's important that, you know, what I say is confidential. Now, I'm not going to talk about names. You're not going to be able to identify them. So I'm very happy for you to record this. But nevertheless, it's important that we remember that whenever we teach about this sort of thing. The other thing is that when I'm talking about situations like this, you will probably be very aware of situations that you've been in, and I want you to just be aware of the impact on you, and that you might find that you'll find it quite hard to hear some of the things that I'm going to say. And if you do, just take a break. You don't have to struggle through. I'm not deliberately going to make it really difficult, but you may just find that something I say impacts on you. So I'm going to show a video, sort of in place of having parents speaking. I'm going to show a video, and I'm going to show excerpts from this video. I mean, everything in it is good, but it's too long. So excerpts of some parents whose baby died a few weeks old on the neonatal unit. And I'm going to hopefully help you to feel a little bit more confident about speaking to parents and siblings. I'm going to help you think a little bit about sort of options available to families, choices that they have. And I'm going to help really embed in you, which already Adib has done brilliantly, the need for staff support. I just wanted to start by saying, and I say this quite a lot, that our attitude to death has changed enormously. And in the Victorian era, it was very common to have a child in the family home after they died, or an adult in the family home after they died. And death was very much more expected. I mean, you know, a significant percentage of children did not survive into adult life, and doctors could do very little. So there was a kind of acceptance. And of course, nowadays, death is absolutely not accepted. And in fact, it's very much the sort of unacceptable face of what we do. And there's an expectation I think people have that we will always be able to cure all children. And that's a big burden on us. And in fact, this is in stark contrast to the Victorian experience of sex, where nobody talked about sex. And nowadays, sex is wide open. So things have changed, but that makes it harder for us. And so there's a kind of a whole group of areas in which you may come across death in hospital. It might be sudden infant death syndrome. I mean, I would be interested to know how many of you have actually experienced this, because certainly in my career, since I started, you know, we used to about something like 1 in 500 babies died from sudden infant death, and now it's fewer than 1 in 2,000, and probably fewer than that now, and it depends on what part of Britain you're in. So you may not have experienced sudden infant death. Neonatal deaths are probably the ones that people experience most out of all the deaths. Death by accident, when there's absolutely no preparation. Death by suicide, which for me personally, having 3 children who have now gone through their teens, but having experience of suicide in children brought to hospital, and also in friends of my children, to me that's probably the hardest thing that I recognise to deal with. And there's also terminal illness, and I suppose that's the one where we can contribute a lot. And I'm very excited by my new job at the hospice, Noah's Ark Hospice, because we can actually produce, with the family's help, a good death, for whatever a good death is. And there's obviously the occasional death through an acute illness, sort of meningitis type death. I haven't actually mentioned trauma. I know that since lockdown, there have been some pretty horrible child protection type issues and some horrible deaths in that way. So I'm going to try and hopefully play you at this clip, and then I'd like you to sort of think about what these parents are saying, and think about anything that surprises you. So let's just hope that you have sound and that you can hear it, and let me know if you can't.
One thing that I think, talking with parents, that probably comes across straight away in terms of improving the quality of care for the baby and getting that right, is that you have to have good communication with the parent, and understanding that that parent knows that child better than anyone else possibly could. They're the person who sits and watches them every second of every day, almost. Day after day, they notice the subtle changes that no one else could see. And you have to communicate with the person who knows all that information to give that baby the best care you can. What, as observers in a neonatal unit, which is kind of what we were for 10 weeks, as someone sitting in a neonatal unit with their baby, we also saw a lot of the interaction between the doctors and the nurses, between the consultants and the registrars, between the registrars and the nurses, consultants and the nurses, between the sisters and the nurses. And what became really clear to us is that, as well as the communication between ourselves and the staff being vital to James getting the best possible care, what was equally important was the communication between the staff, and the fact that when the doctors, different layers of doctors and the different layers of nurses were communicating the best, when they were trusting each other, and when they were sharing information and they were referring to each other's opinions back and forth between those different layers, that is where James got the best care, without a doubt. And that's when he got the best care, because it happened in all the different wards he was on, but not consistently. So it's not that it happened in one hospital and not in another. It happened in all the hospitals sometimes, depending on who was on, depending on what consultant was on that time, what registrar was on, what nurses were on, what sister was on. And it's when we saw that flow of information and that trust running from us through the staff that we could see that James was getting the best care. Because that's when you got the full picture of who James was and what was happening with him. Because the consultants might well understand the medical issues in a way that none of us could. But the consultants won't perhaps get the observations of James that they need to be able to understand what's going on with him, because we've got that, and sometimes the only way it gets from us to the consultant is through those levels, or sometimes with the really good consultants it went directly between us and the consultants, I have to say as well. So it takes that understanding and that listening between all the members of staff, and sometimes I have to say we would trust one of the nurses' opinions way over anyone else who was on that ward or in that hospital at that time, because sometimes it was the nurses, the next level up from us, it's the nurses who got to know James as an individual best past us.
And the best sort of examples you could see would, say a registrar wanted to come and do a heel prick or something, and you could see the best ones would always either ask us if we were there or ask the nurse looking after him, is this a good time to do it? The worst ones, when you see, they sort of just fling open the hatch and do a heel, and the baby, you don't know if the baby's just had a massive desaturation after a change, or somebody else has just come in and prodded him or hooked him up to something 2 minutes ago. It really might not be a good time for him. So that was always good to see when a doctor would actually come and ask, I need to do it, is it a good time? That just, because you would ask a patient if they were just lying in the hospital, as long as they were conscious, you would ask an adult patient, is this a good time to do this, or is it okay if I just do that? And so if the parent is just sitting there, or the nurse is there with the baby, it's just seems right that you ask the parent or you ask the nurse, is it okay if I do this? And I think those are the doctors that you sort of really saw the good communication with as well, where they actually talked about James if he was a patient of theirs rather than something that needed testing.
Yeah, and the doctors who would talk openly to the nurses about James in front of us as well. I know there's some conversations, ward rounds, that we can't be there for, which is totally understandable, but we had to be part of the flow of information between the doctors and nurses sometimes, because if we were always missing, then the people who knew him best were never heard. Little thing in James's story, but as his mother in that moment, if you're talking about what a mother loses when they have a prem baby, that's something I felt in the moment I lost. And now in James's story it seems totally insignificant, but at that time it was important to me.
And then met the surgeon who told us about the operation he would be doing. Again, he went into great detail really about what exactly the issue was and the issues that he might find, and the fact that he didn't really know what he would find during the operation, and so couldn't tell us what the outcome would be. But he was very honest and open, told us that if things went well, James's chances were 50-50. So to think sort of 24 or so hours before we were thinking everything's fine, and now suddenly it's sort of 50-50. So again, yeah, second night, no sleep really, but at least before he went down, it was the last time James was conscious. Obviously he'd been sedated and he was about to be put under for the operation, but he was conscious and aware of us. And I think one of the sort of nice things to know that he knew we were there, and he knew who we were as well, was we were talking to him before he went down, and he always sort of seemed to respond to our voices, but he had hold of my thumb, and whenever I spoke, whenever he heard my voice, he squeezed it really quite tightly. And then when I stopped speaking, he'd sort of relax a bit, and then when I spoke again. So yeah, that kind of recognition, he knew it was me, and that he seemed to be getting some comfort from the fact that it was me. Still, yeah, means a lot to me. Yeah. But like I said, that was
just before he
went down to be operated on.
To be operated on, so it was the last time he was really aware of anything. He was aware of his mum and dad, and that was important to us and important to him.
Okay, so I just use that just to illustrate a little bit about, you know, parents talking. It's not about the actual death, but it's about really good communication. If we were all in a room together, we could talk about what you've learned from that. But I'm sure just watching them, there are a number of things which you probably found we all know, but it's actually taking that time and listening and asking, which is so important. So what have I learned from families? And it's not just me, what have I learned from families, but it's what we've learned through working with Child Bereavement UK. And there are lots of real top tips that will, you know, if you were with me for a whole day, we were running this course, Adib and I together, we would teach, but time, just giving families time and really listening and giving them time to ask questions and giving pauses is really, really important. Being absolutely honest, so important, as honest as you can be. So if you don't know, that's okay, just be honest. Always use clear language. It's so easy for people to go into medical language, and the parents, when they come and speak on our bereavement days, will often say that, you know, very enthusiastic cardiac surgeons might draw very complicated diagrams of hearts, and but if that's not what parents want with very complicated language, then that's not what they need at that time. Always, if possible, have both parents together, and I know at the moment with COVID that's a particularly challenging thing for everybody. And always give parents some choices if you can. I always say, give hope. So if there is hope to give hope, but you can't give hope and be dishonest. So if a child is definitely going to die, you have to be absolutely honest about that. Stay with the parents through the journey. And so listen to those parents talking. They were very much talking about, you know, the communication with all different levels of families, and clearly along the way they will be more connected with some nurses than others, with some doctors than others, but having somebody who will stay with them is so important, and also important after a child has death, particularly for them to know who to come back to, who to talk to, who to link up with. Remain a point of contact and always let families know what's going to happen next. So I've got a few examples I thought that I would tell, sort of, you know, stories that I've been involved with, and stories that had a particular impact on me for various different reasons. So I remember very clearly, very early on when I was a consultant, a child came into A&E who had a volvulus and went very quickly to theatre, but had gangrenous bowel and died. And I was just devastated, and the mother was devastated. And at that point, I would do the thing that every consultant did, which was to offer an appointment in 6 weeks' time to come back and see me in hospital and sort of talk about stuff. And two things really struck me when she came back to see me. Was just the mum came, the dad didn't come, and she came with a photograph of her little boy, and she wanted me to see what he was like when he was alive. That was really important to her. And she really wanted, because she felt that I'd really connected with her and that I would really want to see this child. So that was one of the things that I learnt about sort of really wanting to know, if you've never met a child before, really wanting to know about them. But also I learnt that the reason that parents don't both come back sometimes to an appointment is it can be quite hard for both parents to come back to an appointment, or very difficult for them emotionally. And actually what I always offer now is to go around to families' home if that's what they want. So some families absolutely want to come back to hospital and have a kind of clinical review, but for other families, going to their home, they really, really appreciate it. The next thing, what else have I learned? So I remember one particular situation with a stillborn baby, so being called to see this baby and arriving, And it was a very, I mean, all stillbirths are really tragic. And this one was, if you like, doubly so, because this is a family who'd had years of infertility. This is their first baby. And then there was this full-term, completely surprised stillborn baby. And the midwives were just about to bath the baby and then choose some clothes and dress the baby. And my one contribution, I couldn't save this baby's life, but my contribution was to say to the parents, would you like to bath your baby? And do you have any clothes that you would like to dress your baby in? And it was their opportunity to be parents, their only opportunity to be parents. And so important that that was their role. It wasn't anybody else's role. And one of the take-home lessons really is that after a child has died, never flip your language and start talking about a body. It's always the child, and it's always the child's name. And also never take over a function from parents that they wouldn't normally do. So, you know, we tend to, as doctors and nurses, say, now we'll prepare the child's body. We'll do this. And actually, no, that's what the family will probably want to do themselves. But ask them, they may not want to. They may want to hand over to you completely. Next lesson that I learned, and this was slightly more recently than that, this is a little girl with learning difficulties who was on holiday. Well, her parents were on holiday, so she was staying with her aunt and uncle, who they were looking after her, and she came into A&E moribund with a story that sounded very suggestive of severe pneumonia. And she died in A&E. And the first awful thing I had to do was to phone, with the help of the uncle, phone the parents who were on a stayover in an airport between London and India, where they were going, and tell them that their daughter had died. And then there was this conversation about what they wanted to happen. And the dad and the uncle were absolutely adamant, because they were a Muslim family, that this child had to be buried as soon as possible. And it was Christmas Eve, and I phoned the coroner, and I arranged for the coroner to agree that I could put pneumonia as a cause of death on the death certificate, because that was the most likely cause of death. And therefore we could release this child for burial. And when I saw the family for follow-up, both parents together, the first time I'd ever met them, the mother said, "Why didn't you ask if we wanted a post-mortem?" And I was absolutely shocked, because I had made the assumption that because they were Muslim parents and because the dad had told me what he wanted, I was shocked at myself, because I'll never do this again, that I hadn't actually asked to speak to the mum separately and said, is this what you want to? Probably actually what she really wanted was to be able to see her child again. So that was a real learning point for me, not assume anything, and just because you hear it from one parent doesn't mean that both parents want it, and just because you know what parents' views are, what parents' religious views are, it doesn't mean that these parents will actually want that to happen. The next family that I've really learnt from was a family who, when I was a brand new consultant, their son was diagnosed with a rare liver cancer. And a year after he was diagnosed, he died. And I looked after him for a big chunk of that time. And throughout that time, his father was angry at me all the time. I mean, he was just angry. Every interaction we had was fury. And finally, very bravely, 20 years on, I phoned him. And I've kept in contact with him ever since. And he's fundraised for our ward a lot ever since, after the anger sort of simmered down. And I asked him if he'd be kind enough, both parents would be kind enough to come and talk at our bereavement day and talk about their experiences. And I was really bracing myself for fury, and I did get fury, but actually I didn't get fury about me, because although he was angry all the time, what he said he got out of us at Barnet was that every time he was angry, we listened and we came up with a solution. And I'd forgotten all of this completely. But he also taught me something that made him particularly angry, and that was at Great Ormond Street. And he said that in this session, when he was seen by a nurse after the child had had surgery, a nurse told him that this child had done very well, they'd taken the whole tumour out, and everything was looking really good. And then, following that, suddenly they were told by the doctor, "I don't know why you were told that, but actually we didn't get the whole tumour out and we're very worried. And he said that it was much worse to be elevated to this high level of excitement and then to be suddenly dropped than it would have been if his expectations had been low all the way through. But you can see completely how that happened, because I'm sure the poor nurse wanted to give good news, and that's the information that she thought she'd had. So these situations are always, when anger happens, it's nearly always people doing things for all the right reasons, but not quite getting it right for the family. And the final thing I put on my list here was breaking news to parents with a teenage child at the same time. So again, very early on as a consultant, we diagnosed leukemia in a little boy. And I sat down, he was actually not that little, he was a big 14-year-old. So I sat down with him and his parents, and I explained to them what leukemia was, and that what was going to happen, what sort of treatment he was going to have. And the mother screamed and shouted and ran out of the room, and the father fainted. And I thought, do you know what? It wasn't good to do this in front. I should have spoken to the parents first, explained everything to them, and then talked to him. So I've learned many, many more things, but these are just some of the things and some of the examples. So what can you do? These are other top tips that have come from parents. Remember that all families will receive your help differently. So that means for some families, they'll just want you to sit with them, hug them, pre-COVID hug, and have silence with them and just be there for them. Other families want you to be very active and very proactive and take over and do everything. So just remember, listen to what families want. You know all about breaking bad news and where to have discussions. I don't need to teach you that. But one of the other things we've learned from parents is, what do parents want to be called? Very few parents actually want to be called mum and dad, and that's what we all default to. So every set of parents that I have to talk to us on our bereavement days, I say, and what do you like to be called? What do you like to be called by the nurses and doctors on the ward? And every single time they always want their first names. And I say, what do you feel about being called mum and dad? And actually, it's only really the parents of newborn babies who want to be called mum and dad, because that's what they are finally. But actually, the parents of older children very rarely want mum and dad. They nearly always want their names. I've talked about honesty. Written information, really helpful to families. So you'll say a lot of stuff to people when you're in a grief reaction or when you're being given bad news. Nothing sticks in your head. So write things down for people. I said before, don't make guarantees. So give hope, but don't make any guarantees. And keep, as I said before as well, please remember, when you're handling a baby after death, handle them, refer to them as you would if they were alive. Don't suddenly revert to the body. I'm going to leave some time for discussion, so I'm going to rush through this little bit about grief, because the old-fashioned model of grief was very much about you go through stages, and the new version of grief is nothing like that. It's all about you go backwards and forwards, often every day, into being loss orientated and immersed in grief to being restoration orientated. And that's normal. And a lot of what we say to parents in terms of bereavement counselling afterwards, or seeing families afterwards, is what you're going through is normal, is to be expected. The thing about parents is that often they don't go through the same stages at the same time, which can be really helpful. So when one's loss orientated, the other one is restoration orientated and can support the loss orientated one. And the really important thing to understand for families, if you're seeing them afterwards, is that they will never, ever come to a point where everything's all right again. They will never come to the same point in their lives again. But what they will do eventually is to find an enduring connection with the child who has died in the midst of embarking on a new life. And it's that what you're trying to achieve. You're not trying to achieve it's all right now, because you're not going to achieve that. But being able to carry on with life in a meaningful way while still hanging on to this child that they've lost, that's what you're really hoping for. it's really important to remember that how we're affected is very much to do with what we bring ourselves. And so I'm just going to rush through these, but so and day by day these are going to change. For me, the first time I saw a 15-year-old brought to A&E who had hanged herself in a tree in the garden, she had the same name as my daughter. She went to the same school that I went to. And here was this lovely girl who had hanged herself. I mean, the devastation of the parents. I was absolutely overwhelmed with grief. The first time I saw a baby who died of cot death when I had a tiny baby of my own, absolutely overwhelmed. And yet there can be other occasions when I feel I'm being a bit more clinical about it all, or a bit more contained. So does it get any easier? An SHO once said to me years ago, when we were crying together over the death of a baby, does it ever get any easier? No. If you're going to be a good doctor, it doesn't get any easier. You just develop strategies. And I think if you have a strategy, which is, I know how to support families well, that will take you a very long way, because you feel that you can offer something. So I put something about the debrief, but before we talk about, debriefs are really important, and now more than ever. But before talking about formal debrief, I wanted just to bring up something that I talk about always in the bereavement training days, and that is how we look after ourselves, and that's a recurring theme throughout today. And we had a great meeting on Tuesday with the trainees committee and the TPDs, and we talked about the importance of well-being and the importance of us always maintaining something that we do for ourselves when we go home, and having complete downtime. And we also had this rather brilliant idea during our Tuesday meeting. I think we were feeling really inspired, and that is that we should put in our ARCPs a section about our well-being, about what we do for ourselves. And I usually go around the room in our bereavement days and I say to everybody, what do you do for yourself? And what did you used to do? And sometimes you find people used to play sports, they used to play an instrument, they used to do theatre, and many of them no longer do those things anymore. And sometimes at the end of the day, we make a kind of pact with trainees. We say, and would you like to do these again? Okay, then make time to do it. Find a way, because if you don't find a way, you'll find your life is work, and if you're lucky, children, and then sleep, but you won't have time for you. I'm actually going to leave time here to, rather than talking informally about debriefs, I'm going to leave time to discuss together any questions that you may have. So I can leave that slide up if you like, or maybe I ought to just make that smaller and get back to the meeting so that I can see a few people and take any questions.
Thank you so much, Sue. I'm just going to have a look at the feed to see if anything's coming through. If anyone has anything that they just want to put their hand up as well and unmute themselves. Nothing coming through.
I just want to say, Sue, amazing talk yet again. And given the fact that child bereavement days aren't going ahead, I think that's a really good summary of what goes on the child bereavement days, and we do need to get them up and running. I'm being blinded by the sun right now, but I totally agree with you about the well-being kind of part of the ARCP. I think it's so important that, you know, our jobs are dealing with people, and it takes over our lives, whether we like it or not. It takes over our lives. It comes into our personal life. And so there should be something that, as an education supervisor, you say at the beginning of the year, so what happened last year that was a struggle, what can we do this year to try and make things a bit better for you as an individual, not for your job, you know. So I totally agree with you, and we'll be in full support in helping you design something like that if you need.
I mean, I think that'd be brilliant, because I think a good educational supervisor does that, but actually we don't necessarily document it, because it isn't we're not encouraged to document it. And I think having a slot where we document it would really make every educational supervisor have to do it.
I'd just like to say about my experience of the bereavement day. I went on in ST4 at the very beginning of it, and it was just absolutely brilliant. I think I implore everyone on here who hasn't done it to sign up as soon as there are some slots. I'm sure Sue will let us know when we're going to do that. And I think it was the first time we moved in our jobs, especially when you become a registrar, you go from one case to another. If you have a death, you just need to push on to the next one, it feels like. And it was the first time I sat in a circle with a load of other registrars, and we realized what a crazy job we have, that we see these things, and it's not normal. It's not a normal thing to see in life. So we need to talk about it. We need to find ways of helping each other and helping ourselves. So this day is a great way to start. It's not a fix all, but it's a really great way, a safe space to start thinking about it. And I also remember learning very important thing which I've taken, which is about this emotional pendulum. I don't know if you talk about this, Sue. And it's about allowing ourselves to feel sadness at times, because if you're not letting yourself feel this full swing of emotion, then you're not able to kind of feel the happiness and other things in life if we bottle it all up. So I don't know if you have anything to say about that, Sue.
Yeah, I mean, you probably went on a day that was run by Julia Samuel, who is an amazing person. She's a psychologist who's the bereavement counsellor for St Mary's and has written 2 incredible books. One of them is called Grief Works, that I commend you all to read, and another one is called This Too Shall Pass. So another great book. So she runs the day brilliantly, and I've learned loads from her from a psychologist's point of view, and I run the day from a paediatrician's point of view. And so I always forget to put things like the emotional pendulum in. You know, she uses these great terms, and we used to run them together, and then we realized we had to split up so that we could each do it with a registrar rather than putting us both together, because we couldn't all do it every day. Yeah, but you've reminded me. Great. Well, first of all, you know, I honestly don't think you should be doing the hot debrief. I think it should be your consultant who's there with you, supporting you, who is sort of brings you all together. And really, the hot debrief is about just checking how everybody is. It's not about who did what, and it's absolutely, a debrief is never about who did what. You know, you did that well, you did that badly. It's about, this feels awful. How are you? Let's have a cup of tea. Let's have a hug. And let's maybe sit down at some future point and think together about how we all are in a few days or weeks' time, in a session with a psychologist. That's perfect. That the sort of the cold debrief with a psychologist is what you really need. But the hot is all about sort of care and compassion. So if you are in that situation again, Claire, just make everybody a cup of tea and sit down and say, we need to have a little break now. How is everybody?
Thanks, Claire.
Thank you.
Next, we've got Sabina as well. She's got her hand up.
Hi, Sue. Thank you so much for that. That was really, really as inspiring as a talk like that can be, but it was really useful. And I wanted to share something actually when you brought up the wellbeing PDP, is that what I had done in my last job, which was community paediatrics, is I actually have I've done a yoga teacher training course in the past, just like a 1 month away in India, and I offered to do a regular 20-minute class every week, either yoga, meditation, or a combination depending on what people felt like. And my consultant actually booked a room for this regularly, and every Friday after our team education meeting, we would go to that, and it was optional. You didn't have to do it. Some people didn't want to do it, but it was really great. And I had some really positive feedback, and I felt good about doing it. And it also reminded me to bring my mindfulness into the day. And I guess it was just kind of something that people could maybe take to their teams, because there will be some skills within your team. Somebody might know meditation, somebody might know how to work out, somebody might just make a cup of tea and have those laughs, but it's that scheduled weekly regular thing that you could bring into a team.
Sabina, that's absolutely brilliant. And I absolutely agree with you. I mean, what we're learning today, isn't it, about 10 minutes of drawing, 10 to 20 minutes of yoga, mindfulness, anything really that takes you briefly away from the work and to connect with other people is a really good idea. I noticed you're talking about it in the past tense now, so I'm assuming you don't have an opportunity to do that at the moment.
I'm actually on an oopsie, but I fully plan to bring it in when I rejoin in a month at my next trust. Yeah.
Excellent. So you're on a healthy oopsie.
Yes.
Good. Good.
Can I just add to that it's that's so important to have those kind of coping strategies and not fall into having, it's quite easy to go home and pick up a glass of wine and wine has its place. I'm not gonna say no to those who do drink, but actually if you're finding that you're not that's all you're doing and not doing something that's also good for your mind and body in a different way, then that also is quite unhealthy. I've got a little pet peeve that I wanted to bring up about the debriefs. It's really important that when we do debriefs, that I think we should stop comparing ourselves to pilots or the army in the front line or superheroes. Firstly, we're not superheroes. We're all human, and that's why we're doing these jobs. Secondly, it doesn't work with the army because in armies you're prepared for death and you're prepared for lots of people dying around you. We don't get that preparation as doctors. We actually get the opposite preparation, that we're going to save everyone's life. It's only once you get into the job that you figure out that death is actually very much part of our job. So I think the army isn't a great one. And also pilots, they work with a machine that they know exactly how every single part works, and they know exactly how to fix it and how to break it and how to and what to do when things go wrong. We only know about 30% of our machine that we have to work with, and that's the machine that we're trying to fix. And then there's the machine that we are ourselves, which is the human factor. So comparing ourselves to pilots, I think, actually brings a real negativity into our career, that we're not good enough. Look at them, they're better. But actually what we do is far more difficult than what a pilot does. Just want to put that one out there.
Can I also say that Adib and I have had many cocktails together as a form of a form of well-being. Should we say that?
Yeah, we found a good few bars in London. Yeah, hopefully when they open up again, we'll do it again.
Including one with a beach in it. I don't know how we found that.
Yeah, that's the secret one near Great Ormond Street. So.
Yeah.
That's great. I don't think anyone else has their hand up, but feel free. We've got a bit of time. And if there's anyone else has any comments, doesn't have to be a question, it can be an experience. Like I said, it's all confidential here. So if anyone wants to say anything, but if you don't, any of the committee, any of the guys want to say anything?
That's me, as always. Sue, could you unshare your screen really quickly? Sorry.
Oh, thank you very much. That's a very sensible thing to do. I did so well with my sharing.
Yeah, you did. I really applaud you for that. We got the video and the sound all working. Good. I think you have done incredible. And actually, I should put out thanks to Luke, who is in the group and helped massively with us getting that video playing. So thank you, Luke.
Thank you very much. Thank you. So am I unshared now?
Yeah.
You are indeed.
Good. Good. Oh, I feel so good. The talk's easy. It's the IT that's hell.
Completely agree with that one. So Roland, would you like to take over?
Yeah, definitely. So this was just a little. Firstly, I ended up in a room with no people, so I didn't get to share anything. So
would you like to tell us about your favourite book and film, Roland?
I was going to share something. I feel like I need to share it just very quickly. This is the book I was going to share. Is it back to front?
Devotions.
By Mary Oliver. It's a book of poetry. It's very beautiful. So I just think it's something. I'm not a big reader, so it's short poetry, and it's a very nice thing to look at after a stressful day at work. So I just wanted to share that because I didn't get to share it. So, but really, this session is about your voice, not mine, because my voice is boring. If anyone has anything they want to ask, any issues they want to raise, any thoughts on the day, anything at all, it might be silent, but this is the time to do it. So raise your hand. But if no one has anything, we can push on.
Just to say, really great job. I only got to join in the afternoon, but well done. And thanks for being so open and vulnerable and thinking about everything that the trainees could benefit from. So really great job. And we are here. So those of you who have talked about things they've been through, do reach out. We've got lots of resources. We're always an open ear, happy to have a chat and support you in any way possible.
And I'd like just to say the same thing. I think you've done a brilliant job. I've really enjoyed it. I was just saying to Saranya that I switched from, I was supposed to be in the mental health conference today. And so the idea was I was going to be dipping just out of it just to give my talk and then dipping back into it. But actually this is much better, this one. So I've stuck with this one. And I wanted to say thank you very much to those of you who's volunteered to help me restart the bereavement training. And also B, to help us think about ARCPs and a wellbeing section, and really to think about formalising it, because I think that's the best idea we've had for a long time.
Great.
So shall we round up and then we can get Ciara started with our next session?
Yeah, I think so. So I think there's only a few of us left now. But I think firstly, I just need to flag the feedback forms. So I know nobody enjoys doing a feedback form, but it'd be really useful to improve anything and see how we've done, and also good feedback for the speakers and all the trainees who have spoken. I want to say a massive thank you to everybody. I know Caroline Elton's gone now, but what a wonderful talk she gave us. Sue, always amazing, inspiring talk. And yeah, I think, like I said, I just think everyone needs to go on the child bereavement course because it's so kind of integral to our work, how we deal with it with the parents and the patients, and how we deal with it for ourselves. I think it's really an enlightening course and really helps. Heidi, she's not here anymore, but about creativity and play and using that other side to our brain. I think medicine always used to be seen as an art. I think maybe we've somehow lost some of the art, so it's about bringing that back, the art of medicine and that creativity play, which especially in paediatrics we can do and help each other. Claire from Practitioner Health, I think that's just a really good resource, and we've seen it being used with our trainee stories, so thanks to everybody being involved. TPDs for being here, and just to reiterate that they're there to support us after this, so message if you have any questions. So Jonathan, Tricia, Sue, please get in contact with them, and not just now, throughout the whole of training. They're there, and all the TPDs are always there. I spoke about the I've forgotten what it's called now, the connectivity, not the connectivity sessions, contact sessions. They're always open to people as well, so use the portal to use them. And a massive thank you to the trainees for telling their stories. Sarah, I think she's gone now, Adib and Kaz, really brave, coming online, speaking. It was up to 50 people at one point, talking about vulnerabilities, talking about things about guilt, failure, these things which, and mental health, are really tough things to talk about, and we need to be talking about. So thank you so much to everybody. I think just to say, like, I'm sure we all agree that this is a really special job that we do, but a very hard job as well. And we need to look after ourselves so that we can give the best care, but also be the best in our lives as well. So like Caroline was talking about, this work-life integration, I think is really nice. That's the massive take-home point for me. Instead of work-life balance, it's a work-life integration. So what I can bring from my work and my life, and how I can have it all working together, because I know I can be a better doctor if I'm doing better for myself outside, and then vice versa. So hopefully we've all learned something, and hopefully we can all, everybody here, if we take it into a workplace and share things, share the resource pack, share little ideas. I know Ciara's going to, is it Ciara or Ciara, going to give us some breathing techniques, all these little things, the drawing sessions. I think we can share that, and we're an amazing community, and we need to be helping each other and supporting each other. So I think that's probably what I want to say and what I've learned. And just look at the resource pack. Kaz gave us some great ideas. Educational supervisors there, PSP, PSU, LSP. It's about helping and finding the help when we need it. or before we need it. So, but yeah, I'll let other people say something as well.
Amazing, Roland. So just addition to that, before we get cracking with our last session, which is such an important session, which I can't reiterate, which I'll go into in a little bit, but I just want to really, really thank Saranya, Ciara and Roland, who have come together to put together today and really made it everything it was. It took a lot of hard work and a lot of thinking about how to make this the best structured day possible. The reason we're doing thanks and everything now is because Ciara is going to do the next session, which we're going to move on very swiftly to. So Ciara is someone that Trisha, one of the TPDs, put me in contact with ages ago now. I've known her for a long time. She is an inspirational woman who is actually a patient herself, and actually she was working in the financial industry and then changed her whole sort of career path onto this amazing focus on our inner selves and thinking about health and our minds. You can see there's loads of information which she's included on our resource sheet, because she's got a book published and also a website called Wholly Aligned. I've got a copy myself. I've read it, love it. I've watched lots of her videos. During lockdown, she actually gave me a free one-to-one session of sitting and thinking about things when I was feeling really low and lonely. And I can't recommend her and all of her great thoughts herself. And recently, she's just become a trustee for the British Holistic Medical Association. And if you don't know what that is, because I didn't, have a look, sign up to the newsletter. They have incredible days and conferences, all looking at our holistic care as practitioners. So please do have a look at that as well. I'll put up the link later. So a warm and hearty welcome to Ciara, who is going to end our session with some great mindfulness, relaxation and breathing.
Oh, thanks so much, Nisha. Can you hear me and see me okay? Yeah, is that all right? Okay, awesome. It's so lovely to share this space with you, and I'm completely aware that it's been, well done, Nisha and Roland, for kind of steering a very, very strong ship today, because there's been a lot. I did dive in this morning and I listened to Caroline's keynote, and I hopped back in around 3 o'clock. So I've heard bits, but I'm also very much an advocate of meeting people where they're at. So, no matter that people have dropped off, it's understandable. Lots of people are going through huge transitions, processes of grief. So, there might have been stuff that came up today that they need to just go away and have a little bit of reflection space. So perhaps this provides also more opportunity for a bit more interaction after I've kind of guided you through some bits and pieces. So please know that I'm there for you. What I would love to do, because we all know the importance of balance, and I love that the word integration came up right at the outset, like fresh out the gate, integration is there, because ultimately yoga means that. You might hear, if you have explored the realm of yoga, it's highly complex, it's a technology in and of itself, but you might have heard yoga means union. That's kind of a little bit of a simplistic way of looking at it, because it can sometimes create the idea that, oh, if it means union, then I'm separate. And we get very caught up in no one understands me, nobody can possibly know what I'm going through, and that it just amplifies this message of separateness. And I think we're coming into an age now, which is why we've been asked to go into such powerful transitions with what's been going on globally, where everything is up for change. Everything's out of the box, right? And that is extremely hopeful and extremely powerful, and why I love all of you is because you get it. And for Nisha to have said at the beginning that even for her own notation the past 5 years how much cultural change she's seen, and I would echo that. So I have had, if you like, let's put it this way, 40 years of renal medicine experience, probably about 30 odd of those being directly in the NHS. So having sort of traversed from a diagnosis of a rare form of nephritis at 4 years old So my mother would have navigated paediatrics. That was at a time when we were living in Ireland. My mother is Irish. And my parents actually made the decision in the best interest of my health to move to Zambia. I only know this now, well into my 40s, that, oh, okay, that's why they made those decisions. And being able to have those vulnerable conversations with our family is so precious, because we don't always have the opportunity to do that. But I am so fortunate and so blessed to have grown up in the bounty and abundance of Zambia, which I hold so dearly in my heart for all the messages around holism, if you like, that we grew up in the sunshine, plenty of natural vitamin D, that although I had this diagnosis, I didn't know it was progressive. My parents never shared that with me, which is incredibly brave of them. And I was very well. Inevitably, because of a progressive condition, I went into renal failure when I was 14. We were back in the UK then. I won't go into too much detail around the story. You can watch my TEDx talk if you want to hear more of that. What I'm more interested in is kind of giving you the tools that are really going to be helpful, and to be vulnerable with you as well. So I'm navigating quite a serious viral infection, not the great unsaid one, but CMV, which in an immune suppressed profile can cause all kinds of minxiness. So I had my second kidney transplant in October 2019. Came in very strong, worked straight away, but for whatever reason, and who knows what goes on in the bigger picture of these things, CMV developed from the kidney in the summer. So I'm still doing a little bit of navigation around that. So I just share that because it means that I've been at King's pretty much on a weekly basis these past 5 months, navigating all kinds of things. So I kind of, it's like, oh yes, okay, that makes sense. Ciara, who has a passion about creating an integrative health system, needs to be, that's where you need to be. That's where you need to be, you know, drinking in the medicine and seeing it up close. And renal medicine historically is highly medicalized. It's very hierarchical. And so it's kind of been a big passion of mine to sort of break down some of the silos in that because of my direct experience. So I'd like to share first and foremost some techniques around your breathing. The breath, we could study it for years and there would still be so much mystery in it. So there's great mystery in it. But what is also very hopeful is the immediacy that it gives us. So you'll know yourselves, because, you know, I've heard some of you talking about mindfulness and yoga and, you know, the creative arts, using different things to help, that there's something in you that will change in your capacity to self-regulate when you move towards things that are a little bit more uplifting. And this is sort of the compelling neuroscience around it. We can totally geek out on the neuroscience, which I love, but I also want to really immerse and feel the experiences, and that kind of requires a depth of spirituality, if that's phrasing that lands with people, because ultimately, you know, the human spirit is tenacious and stronger than we can ever really know. So I'd like to just read a little something from this book that I highly recommend if it's in resonance, The Secret Language of Cells. It's written by a neuroscientist and a physician. It's a recent publication from 2020, and it's, let me read it. Read you a little bit of blurb and see how it lands with you. So right now, both your inner and outer worlds are abuzz with chatter among living cells of every possible kind, from those in your body and brain to those in the environment around you. From electrical alerts to chemical codes, the greatest secret of modern biology hiding in plain sight is that all of life's activity boils down to one thing: communication. So with that being said, what we're going to do is, the invitation is to sit in the liquid volume and the rivers and streams of your own body, and we're going to do some breathing together. There's also something tremendously healing about sitting as a group, even though it's virtual, that everything is operating at an energetic vibration. There's something very hopeful, very healing about sitting together and breathing, because we will actually start to sync up our brain waves and heart waves, which if we could even imagine the whole world, 7.5 billion people breathing in a rhythm of coherence, which is simply meaning we're breathing in for the count of 6 and breathing out for the count of 6. Even imagining that, you can feel in your own self the possibilities of change that would emerge from that. So the invitation is to close the eyes. If that feels too big an ask, then I would suggest that you keep your eyes downcast, just to kind of, you know, the eyes are so close to the brain. Movements of the eyes and constant looking at screens we know, I don't need to tell you that has an impact on our nervous system and on our homeostatic balance. So let the hands rest where it feels comfortable for you. And just first, in the here and now, simply observe the current quality of your breath. Nothing more, nothing less. That perhaps this is not something that you're so familiar with, and it's okay. It's okay. It's like maybe the mind is taking over, or there's a bit of a struggle on the inhale, or you're not able to exhale or decompress. So you're simply just in the compassionate observation of your own current quality of your breathing. So the mouth is softly sealed. And in this pattern of what's called coherent breath, it's a term coined by life scientist and engineer Stephen Elliott, who's done a lot of research around this. If we just allow ourselves to land in a little bit more harmony, a little bit more equanimity, a little bit more coherence, what might change inside of us? What shifts, what changes? And why does that matter? And only you can know that. The reason we breathe through the nose is because as a human body, we are designed to breathe through the nose. The mouth is an emergency backup. So in a modern world, we might have all sorts of sleep apnea issues, big links between sleep apnea and dementia. So to learn a skill that even if you just start to become more aware of your own breath and to plant the default seed of your operating system to breathe through the nose, that would be fantastic. That would be awesome. So for the next few breaths, just as we'll begin to guide into the 6-6 breathing, just simply notice how you feel about breathing through your nose. Maybe it comes naturally, maybe there's some struggle there. Without judging it. We're very good at judging ourselves. We're very good at self-sabotaging. We're very good at driving ourselves insane. And we don't necessarily learn these messages of ultimately self-love when we're young. But we can learn them now. It's never too late, never too late. So wherever you are in your breath cycle, just take a big exhale out the mouth to loosen off the jaw. Mouth softly sealed. Inhale through the nose. The invitation is to take the breath down and wide into your belly. And exhale out the nose. Mouth softly sealed. Breathing in. 5, 4, 3, 2, 1. Breathing out. Out, out, out. Inhaling, imagining your heart waves, your brain waves starting to sync up. And exhale, what do you need to let go of? Maybe you're in a deep state of grief. It's okay if emotion comes up. You're allowed to feel. You're allowed to feel. Breathing in. Maybe it's tricky to access your belly. It's okay. All comes with practice. Exhale. Imagine you're exhaling out your feet. So suggest that the legs be uncrossed and your feet are to the earth. Breathing in now through your feet. We have so much sensory information through our hands and feet. And breathing out, gently observing. Are you a chest breather? It's okay if you are, because you can change it. It's okay. Breathing in. The invitation is to keep the shoulders soft and let the belly rise. And exhaling. 4, 3, 2, 1. 3 more rounds together. We breathe as one. Breathing in. Breathing out. Perhaps introducing a little baby snore at the back of the throat. Inhaling, self-regulating, self-soothing. And exhaling. Out, out, out. 1 more round together. Breathing in. And breathing out. Let your breath regulate to where it wants to go. Maybe you blink the eyes open. That's completely fine if you have. But to just take a moment or two to notice what's changed, what's shifted, because it's very important that the conscious mind has a register that, oh, something in the somatic nervous system, something in the feeling has changed, because then we're probably more compelled to do this again. Excellent. Good. And know that this breath, this great untapped resource, this is in you always. For as long as you are residing in a human body, this resource is there for you always, always. Let your eyes gently open if you have kept them closed. Yeah, I can feel already a settling. It's really, really beautiful. So I'm going to introduce, because, you know, maybe you're somebody that lives alone and you haven't had a hug for a long time. We're going to do like a little self-hug. So there's lots of benefits around this. It's about creating a shape in the body that is soothing. So you're going to take the right hand and place it under your left armpit. And just gently rest your left hand on the right shoulder. Yeah, so you'll know that the walls on the left side of your heart are thicker, that the anatomy of the heart is quite centrally located, but of course the thicker walls, because that's what pumps out the oxygenated blood, they need to be thicker by design. You're more likely to, of course, feel the rhythm of your own heart rate on the left side. You're welcome to close the eyes again. And to notice, because we have so much sensory information through the hands and feet, are you gripping? Are you clawing? Are you hanging on for dear life? What changes when you just soften through the feet and soften through the hands? And to connect with the rhythm of your own heartbeat. And let's do 3 rounds of breath together, just to land in a hug for you, a hug of love. We can call it a group hug if that resonates. Breathing in. And breathing out. Inhaling, you're allowed to receive. Exhaling out the base of the spine, safety and blessed relief. 1 more round together, breathing in. And breathing out. Great, let the hands relax. And you can again allow the eyes to gently open. And you know, if you want to stay in that embrace a little longer, you're so very welcome. It is something beautifully simple that even, you know, maybe if you're having a hectic moment or you've got certain things that you're having to do, you're rushing around, you're having to prioritize situations in your work, you could always just do a little hug when you go off for a toilet break. It's really fine. Even imagine yourself doing that. So I'm going to segue now into, you know, having kind of landed a little bit more into just kind of giving you a little bit more of the so what's, you know, why is it important? Why is this coherent breath important? What we're actually doing is putting the brain waves at the alpha theta border, where there is access to the greater amount of neuroplasticity. So just share that, because, you know, some people learn logically and some people learn more through feeling, and there's always a balance, there's an oscillation between those things. But in case that's helpful for you to know, that there is this absolute effect on your physiology. And if we consider how the body mind, we can't separate them, that the integration, they're always dancing and weaving together. And the great conductor of so much of that is the quality of our breath. So even if you said to yourself, you know, I'm just 1 breath away from the sweet repose of coming home to myself. And this does come with practice. So don't be worrying if, you know, you do it on your own and you're not feeling it, that it comes with practice. The brain learns through repetition, especially if we've been in a prolonged pattern of high stress and homeostasis has been very sort of out of whack or out of harmony, if you like. I'm going to segue into more of the imagination. So this is, again, we're not necessarily taught so much of this growing up. But who do we talk to the most and who do we listen to the most is ourselves. So we better be running kind of a dialogue that's kind of a little bit kinder, a little bit more of a cheerleader. And, you know, if you haven't learned any of this stuff, please be kind to yourself and know that you can change those inner dialogues, because it's really where it's at. And the breath is so helpful to create that relax, that release, that sweet repose, and starts to influence the very complex biometrics. If we think about the secret language of cells, and it's all about communication, you are the shepherd or the governor, you know, whatever appeals to you, the orchestrator of that communication. So we can start to then understand that relationship with self is so important, because when we have a healthy way of relating to ourselves, we're then able to have a healthier symbiosis with other, because life, you know, relating is one of the most challenging things in the human complex, isn't it? So if we get prompted or stirred by a situation at work, for example, or you're dealing with the death of a child and then the trauma of the parents, that it's very easy to get whipped up and start to feel everyone's emotions, which is not helpful. So it doesn't mean you're wrong or bad for doing that, because a lot of people, I'm sure, in paediatrics are empaths. So it's about finding healthy boundaries. So to feel that it's okay to say no to things, it's okay to follow the things that light you up more, because then we start to change the messaging of our operating system, which changes the conversations in our cells. And we cannot emphasize enough the imagination, and I'm sure some of the creative stuff that you've explored today has brought that piece in. You know, it's why we love stories, isn't it? We love Alice in Wonderland, falling down the rabbit hole, and that she has the capacity to drink something and become smaller, and then drink something else and become bigger. And that we need to shapeshift in our lives, because life is full of change. So we become adaptable. We become more aware of how we can hone our capacity to adapt. So it's just using our imagination. Put it this way, worry, as one of my teachers, Ben Wolf, says, worry is a misuse of the imagination, and yet it will be a default for so many of us. And, you know, I always include myself in all of this as well, because, you know, we go into the spins and the spirals and the what ifs. It's like, oh, but what if this happens again? Or what if, and we start to almost create the reality as it's unfolding. So it's very, very important that we hone an imagination that is more hopeful for ourselves. And how lovely that you are people who work with children. So I don't need to tell you that children are like you're going to be learning from the children that you come across, because they're not going to be so censored. And of course, that's going to vary depending on what their family dynamic is, and what, you know, sometimes it might be very difficult. They might not be able to express themselves at all. It varies, doesn't it? It's very nuanced, it's very complex. But I'd like to bring in this visualization technique, and it's you can think of it as being called 9-to-1. So we use a combination of numbers and pictures, because if we think that the left brain is the part of the brain that describes, where we often get stuck is that we get stuck in the narrative and we keep describing our story. If I use myself as an example, oh, you know, I had kidney failure, I've had 2 transplants, it's like that's just kind of a story. It's not very interesting in terms of the work that I know I need to do in the world. So I need to make myself much more interested in being a pioneer and being a change maker, in challenging the status quo. And we can do that. So I really want to lay out the gauntlet for we can live impossible dreams. We really, really can. So it's about changing the level of how the left brain describes, because we've evolved with the negative bias, right? And that's why it's so compelling. It's like Also, if you are interested in the neuroscience, you might find Lisa Feldman Barrett's TED talk on how emotions are made very, very interesting. She's one of the top 1% cited scientists in the world, and she's very accessible in how she speaks. So it's about the brain predicts. So it's going to predict based on the past. And if we don't catch that, and if we're not aware of that, this is where we get caught in the repetition and the, oh God, the catastrophizing and the dramatizing, whatever our psychological pattern is, or our family of origin, how we've been conditioned growing up, right? So this is like, we've got to get this left brain describing things a little bit better. But numbers really work and appeal to the left brain. So in the 9-to-1 that I'll guide you through, we also then marry the right brain, which is our creative brain, our intuition. Some situations need intellect, some require intuition. And as medics or as trainee medics, you're allowed to use your intuition. It's really important for you to know that, that sometimes that can get squashed. It's the hierarchy that happens. You know, if you don't have a supportive consultant, for example, who's just going to dismiss of like, you know, or you're not in a space where you feel you can vocalize, I think this is what's going on here. You're allowed to do that. You really are. And that comes with, you know, finding your voice within. And that's, again, that's a process. It's really a process. So the right brain depicts. So where the left brain describes, the right brain depicts. So it's the pictures. The pictures in our head create the stories in our head, create our life experiences. So if we're running pictures in our heads that, you know, we're still ruminating or marinating in a traumatic event, it doesn't mean this is easy, right? If it were easy, we wouldn't need all of these tools. And we wouldn't need reminders every day. You know, I'm a yoga teacher. I'm a nutritionist. I need to remind myself every day, because every day is a blank canvas. And can we wake up each day knowing that? It's that we don't need to repeat what's gone before. So the 9 to 1, we'll use numbers and we'll use pictures. The invitation is, so you might find that you're willing to close the eyes here. The invitation is to land back into that rhythm and coherence of your own breath, so that you're accessing, even if it's a suggestion for now, you're starting to access the feeling of the theta, the alpha theta brainwave, where you can access the neuroplasticity. We don't keep needing to repeat the same pictures in our heads, that we can make your brain your greatest ally, because its power is extraordinary. So I'm going to invite you to bring a situation or a person, or, you know, maybe you've got a health situation going on at the moment. Bring it to your mind. Bring it to your mind. It's a bit like the Tibetan dream yoga practitioners say, you've got to dial it up. You've got to dial it up, otherwise you can't delete the file. So dial it up. Don't be afraid to dial it up, and dial it up in a way that resonates. And if loads of things are dialing up, then just put them all into being the thing, the one thing. So trust your intuition here, what's come up, the person that's getting on your nerves, or, you know, you're overwhelmed, or, you know, you've had a falling out with somebody, whatever it is, dial it up. And then we're going to use this 9 to 1 visualization to see if we can change it. And we can, so please know that. So landing in the breath, we come to the number 9. So in your mind's eye, you see the number 9, and then it turns into the image of a balloon on a string. It's a balloon on a string. And you can see yourself holding the string in your hand, and you're putting the thing, you're putting the situation or whatever it is you want to put in the balloon, and then you're letting the string go. So it's away from you, it's floating away from you. You hone the power of your imagination to get it away from you, so you're not feeling that you're right in the loop. We come down to the number 8. It's the shape of a snowman, isn't it? The snowman made of snow, and the snowman is saying, hey, just chill out about it. Just chill out. Can you find just a little bit of chill? Stay in the rhythm of your breath. Whatever happens, it's okay. You don't need to change it. We come down to the number 7. The image is a Swiss Army knife or a penknife. So that can we use that penknife to cut through a situation, or maybe you're cutting the cord with that person. Maybe a family member is too much in your field at the moment, and it's taking up too much of your own bandwidth where you need that for yourself. So what needs to be cut away, or what needs to be diminished? Use the imagination in your best interests. We come down to the number 6. The number 6, it's a plump cherry, that beautiful color of a cherry on a stalk. Maybe you can really feel the colors. You know, some people feel colors rather than see them. Synesthesia. Put the cherry on top. Could you put a cherry on top of the situation? There's always some glimpse of learning or lesson in the situations. Sometimes we've got to walk through these very, very punishing fires to alchemize and to transform. We come down to the number 5. It's the shape of a hook. Maybe you feel like you're literally on the hook, or the situation is on the hook, or your nerves are on the hook. Let your imagination reveal the subconscious. Let your imagination reveal the subconscious. Don't be afraid of it, because you bring it, you dial it up, and then you can change it. You can change it. So the 5 is you're off the hook. You're off the hook. Stay in your breath. Stay in the coherence. Mouth stays softly sealed. We're down to the number 4. It's the shape of a sailboat. So maybe you're somebody that loves the water, that fluidity, the oceans, the vastness, the salty seas, that you're in the boat, you're just sailing away. You're sailing away. There's something calming, there's something tranquil, perhaps. Sail away. We come down to the number 3. And we look at the number 3. Can we see open handcuffs? The cuffs are off. The cuffs are off. You don't need to be enslaved by that situation anymore. It's your mind keeping it alive. Change your mind, change your life. The cuffs are off. The cuffs are off. You come down to the number 2, the shape of a graceful swan. If you find it easier to imagine a duckling, if that's comedic for you, some people can have associations with swans that make it work for you. But if the grace and elegance of a swan works, the calm, the purity of the color white, that there's something calming, isn't it? When we look out at a landscape of snow, there's something calming. The brain responds very, very well to color. So you're not just going to swan about. Just swan about. It's like, hey, I'm just going to swan about. Grace and ease, grace and ease. I move forwards with grace and ease. We come down to the number 1, the number 1 that reminds us we are all one. We are all in this together. Practitioner, patient, planet, self, other, environment. Unity. This is what we long for. We long to be seen for who we truly are. We long to feel united. And the 1 reminds us of that. You might bring a visual of a candle flame or a pillar of light. That light is that which dispels the darkness. That can you imagine even your own glial cells lighting up like starlight? That something changes, doesn't it, when we look up at a starry night? Something changes when we remember our vastness that was there all along. It was there all along. You were never broken. You never needed fixing. You were whole all along. And then just land in the breath. Just land in the breath, breathing in. And breathing out. Inhaling. And exhaling. Breathing in. Coherence, equanimity, sweet relief. Breathing out. No contraindications with this coherent breath. None. One more breath together. Breathing in. Breathing out. Again, just have a little moment to notice with the conscious mind what's changed, what's shifted. And then you let your eyes gently open, gently open. Yeah, good. So I would love to hear, and if you want to say it out loud, please do, or if you want to prefer to put it in the chat, something around sharing your experience around that. And if it's that you know, you noticed, because the breath and the pattern in the breath can reveal so much to us about our own inner state. And that this coherent breath is really about breath for health, because that's what we're interested in. We're interested in creating, you know, good homeostasis, so that everything can become. We are by design very efficient, so that we want to amplify that efficacy inside of us. But it's, you know, if we're not used to doing something like this with breath work, you'll notice things that maybe it's difficult to inhale, or it's difficult to exhale. So any questions around that, or pop something in around what was useful in any of those. So be it the self-hug, be it the coherent breathing, or be it the visualization. Was relaxing but found it difficult to stay focused on the exercise, kept having distracting thoughts. Yes, and that is completely fine. So this is always going to be about a personal evolution for you. So there is never a requirement or an expectation that, oh, I'm doing my breathing now, I must have some kind of Zen experience. Please don't do that to yourself, because this is great. That's what you've noticed. You know, you've noticed that on the one hand it was relaxing, but that there was challenge. There was challenge because we're not trained in this stuff, right? So you've got to be kind and compassionate to yourself in the exploration and not give up. And it might be that, you know, just something as simple as doing 3 rounds of that breath. When you remember, You don't even obligate yourself to do, I'm going to do it every day, because then it's the left brain is going to take over and go, well, you're not good enough if you didn't do your breathing. Well, we get caught in these patterns, don't we? So please know what can be helpful if you are somebody that appeals to imagery is that to imagine the vastness of the blue sky, and that your thoughts are like clouds. They're ephemeral, that they're allowed to pass. They're allowed to pass, that your true nature is the vastness of the blue sky, or the vastness of an ocean, that we have access to this vastness. That how can we possibly know the fullness of our human experience when we're made up of trillions of cells, and that in every given moment there are these cellular conversations happening. So it can be very difficult and very challenging to turn inwards, because we've not been trained to feel. We've been trained to, you need to do it this way, or you need to learn it this way, or this is how we do it around here, or whatever it is. But this all comes with practice. It really does. So thank you for sharing that, Cos. Sabina, I like the countdown visualization. I had a bunch of thoughts, responsibilities, crash into my head. Yeah, crash, like it's like, whoa. And each number had a unique way of letting go of certain thoughts. How can we recreate this again in our own practice? Is there a name for it? I may forget what each number represents. Thank you, Sabina. That's awesome. So this is where I can say, hey, check out the resources, because here's one I made earlier. I made a little video with these techniques. So if you feel like the countdown resonated, and it won't for everyone, that's fine. You can just go to that bit in the video, and you'll get to a point, Sabina, where it will just be natural for you. Because it's very good. This is about kind of creating memory palaces in our brain, so that we can kind of, I don't know, go to our special place. We can go to our special place like that. And that comes with practice, but know that it's possible. Know that it's possible. Yeah. So that, that was the first time you've done something like that. So don't be worrying. You'll have that resource. Or it might be, oh, I found the snowman chilling out really helpful. And it could just be, hey, maybe I need to work with the snowman for a bit. So don't feel like this is what we do to ourselves. If I don't remember it all, then it's not good enough. And it is the fact that you were willing and courageous enough to do it and share your experience. That's awesome. My snowman melted. Is there too much fire? Too much fire maybe going on. It's maybe use a snowman to cool down a little bit. But we need that energy of fire as well. I know I'm very fiery, so I also need to remember to calm down a lot. Yeah, thanks, Nisha. Awesome. So yeah, well, let's do this. I did, because it's the technology thing, I'm certainly not going to expose you to me taking out my guitar and singing to you. I did have a thought of that. So I don't know if the audio will kind of quite work and might go terribly wrong. So instead, it's a song that I wrote. I am, as much as I love the neuroscience, as much as a key piece that I missed to say to you earlier, that I kind of, through my own alchemy and being so in the NHS for so many years, and seeing, like, from the 90s where all these kind of middle management came in, and noticing how people were responding. And as a teenager, you see things a lot more clearly, and like, oh, why people they're a bit upset by these suits that are wandering around. It's like middle management came in, and it superseded the power of the matriarch, the matron. The matron is sorting it out. And then the rise of the superbugs, MRSA. It's like, it's like, wow, we really sold ourselves some lemons in that process. So I get it. I just want you to know that I get it. I've done a lot of research into this. I've attended events with the King's Fund, including going to see people like Simon Stevens and Matt Hancock speak, where it's like, okay, that's great, but it has its place. It's not, can these people really understand? But also, can we be compassionate for people who are in a role that, quite frankly, I wouldn't want to be in that role. But it's very complex, right? It's complex. And I want you to know that I understand the complexities, because I'm interested. For me to be efficacious and a change maker in the system, I have to understand the complexities. Do I have meltdowns about it sometimes? Yes, especially when I'm navigating my own personal stuff at the same time. So I share that because I know you're all doing the same too. You want to be an excellent medic. you want to pass your exams, but you also, you know, it's humanity and humility, right? And these are the things that are going to create change in the world. So we want to really create what is the post-COVID world? What's it going to look like? Because we need to use this space to reflect on who do we want to be, who do we want to emerge in a post-COVID, because it's not, oh, we'll just go back to normal. No, please, because this is huge change from crisis to opportunity, from emergency to emergence. And we can only do that by doing our own sweet work and being incredibly gentle and being incredibly loving to ourselves in it, which again, if we're not taught this stuff, it's really tough, right? So break down to break through. You're allowed to have a meltdown. So, you know, the melting snowman, it's like you're allowed to, maybe that was like you've had your meltdown. Now the snowman helped you have your meltdown, and you don't need to have a meltdown in any other shape or form. Perhaps. Okay, so the brain learns very, very quickly. So instead of singing to you, I'm just going to read out a song that I wrote last year, because music and dance have been huge pieces in my life. And I, you know, it's something that if we want to do, so do sign up for the newsletter thing that I've done, because it will mean that you'll go onto my mailing list, but it's the LSP have kind of called it its own subgroup, so that, you know, we can kind of work with ideas, because everything is out of the box, everything is up for change, and I really want you to know that you don't need to hold yourself back. I could never have envisaged that I would be doing something like this. You know, 10 years ago, I'd go in for my bloods. Yeah, thanks very much. I'm not going to talk about how I feel. It's none of your business. But then, of course, you know, things happen in life, and you've got to reorientate, and you've got to kind of say, okay, how can I be a change? How can I be a change maker? And I know you all understand it, because you're awesome people. So you might like to close your eyes for this whilst I rather than sing to you. I can't guarantee that I won't break into some kind of song. You know, maybe it will amuse you rather than anything else. So just land back in your breath again, land back in yourself. The morning star visited me last night. Everything's topsy-turvy. Who told you that might was right? All I know is everything is changing. And all we need is to meet each moment bravely. I can't guarantee I won't cry. So if I do cry, I'm going to ask you to cry with me, because it's important that we do that for each other. Sing, sing, sing out loud. Find your voice. It's your real power now. No holding back from shining your star. No value in hiding, staying trapped in your scars. All I know is everything is changing. All we need is to meet each moment bravely. Dismantle your shadow with the love of your heart. Do the great work. Break down those walls. Be your own guide, for you always know. The wounding and the wonderment are all part of this cosmic show. All I know is everything is changing. All we need is to meet each moment bravely. So know that you have resources inside of you that are beyond imagination. That when we get stuck in worry as a misuse of imagination, when we get stuck in fear-based thoughts, we need to remember that we have so many tools inside of us, and that the breath is such a great place to start with this, and that you're not just a pediatric trainee. You're a man, you're a woman, you're a son, you're a daughter, you're a mother, or you're becoming a mother soon. You are so much more than just one thing, and that just like diamonds are created in the earth, they're created from huge amounts of pressure. It's pressure that creates diamonds, and diamonds are multifaceted, and we are very, very complex creatures, but what actually keeps us well and unites us is unity, and is our recognition that I am another you. I see you. I am another you. So I will end it at that, and very happy to take any more questions, or, you know, have more of a talk. I know probably the organisers are like super tired, but I would also love to hold space for anyone that needs it. If you want to ask me a question, or if you want to share anything about where you're at the moment. Yeah, well, thanks, Sue. Thanks, Ophelia. So I actually ended up in, so poor Roland spoke, well, Roland maybe hopefully had a conversation with himself, because we need to have conversations with ourselves as well. Hey, how you doing? I often speak to myself in the mirror. Hey, what's going on there? You know, God only knows if people were watching me through the window, you know, being, oh my gosh, is she okay in there? And I say, yes, I'm fine. I'm fine. I'm having a great conversation with myself. But Ophelia was sharing that she's in her trimester, so she's growing a baby. So that's so wonderful. And yes, it was just Ophelia and me having little chats. So yeah, is there anything that, and please don't feel that it needs to be anything other than what it is, because I'm delighted to answer questions.
Ciara, I just want to say that that was a beautiful song, poem, and I would love it if you could, if it's on your website, that we could share it, because they were really emotive words. You basically nearly got me in tears by the end of what you were saying about we are more than just paediatricians. And when you started saying that, oh, I was like, oh no, I'm gonna cry, because we forget that, and actually it's so true. And I really want to thank you for sharing that and making us think about, you know, that we're more than just our jobs.
Yeah, that's it. Thank you, Nisha. It's so lovely, and it is, for me, it's so humbling that little did I know when I reached out to Trish on Twitter, you know, it's probably a couple of years ago now, coming up to that it would end up being this, and that you, Nisha, and Trisha are very dear people to me. And yeah, if I start boohooing, it's because I'm just so replete with a sense of connection and love. But it just means so much, and that we change the world through relationship. It's all about how we relate to one another, and that can we really see, and this comes with challenge. And for me, can I really relate to a nephrologist who I might have created constructs around, you know, these people are just coming at me constantly with things that I'm not able to assimilate or integrate or digest. For me to now be able to orientate, and they are seeing it because the change in the world that's been going on. So I will share another hopeful story actually around a wellbeing platform that's been created for renal patients called Kidney Beam. And this came off the back of one amazing woman, really, Charlene Greenwood. She's an amazing renal physio. And in a matter of weeks, they invited me to be the yoga teacher for the platform. That it's there, and it's been funded by Kidney Research UK. It's got the full backing of King's College Hospital, and I'm part of the steering group. So amid, you know, nephrologists, physios, researchers, and that feels really exciting. And I think when we look at things through a holistic lens, that and given the history of renal medicine has been very, very medicalized, very, very hierarchical, to see that emerge from basically COVID, because it came from a concern from the physio team that we're really worried about our renal patients. And they, you know, to your point around paediatricians not meeting death quite so much, but still being very impacted by it. Having been an inpatient over August and September for a couple of weeks, it was really useful for me to like talk to people about, you know, recognizing that, okay, I'm having quite a crisis here, I need to look after myself, but also I'm interested in hearing how, you know, how's everyone doing in this. Being very humbled at how people were showing up. But one of the nurses, his name's Wilfred, and he's awesome. You know, he said, I couldn't cope. I had to take a month off. It was just horrendous. There were, you know, security guards on the doors. We lost 60 patients in that first sort of wave. And that's a lot to have to deal with, you know. And many of them would have been elderly or on dialysis. So it's just, for me, who's had a combined time of 10.5 years on dialysis at different junctures in my life, I kind of look at it, I'm very interested in shamanism. I look at it as that was my rite of passage from 14 to 21, and I needed to kind of go into that deep cave and understand, what is it to be human? What is it to overcome these situations? And again, the reminders we're so much stronger than we know. And that it's very important for me that I would be letting myself down if I didn't share this with the world. But it does require inner work. So I don't say this lightly, you know, we have to do our inner work and love ourselves enough to do that, to take care of ourselves. So it's much more, I'm kind of re-languaging the self-care, because it's self-love. It's love. It's love, love, love. That can we love ourselves enough to do what we need to do, and to be in that humanity and be in that humility, because tomorrow is never guaranteed. It never is, and it never will be. So, you know, can we be in this moment more often? Yeah. Good. Yeah. So yeah, I can pop the link to the song if people actually want to hear it as a song. I can send that through to you, Nisha. That's completely fine. Yeah. Yeah. Thanks, Sarah. Yeah, but you know, I'm happy to stay on, even if it's just for some after chat or for a few minutes. Just let me know. No obligation. Equally, if you're like, oh my God, I'm so exhausted, I need to like get off the screen, that's fine too. But you know, please, if there's anything else that you want to say or share, do.
Great. I just want to say thank you to everyone and everyone that's here today. We have recorded some of the sessions, so hopefully we'll be able to put them up. But for now, have a really peaceful and lovely evening, and enjoy your weekends coming. Okay, so thank you everyone for sharing today and being in this lovely safe space. All right, take care. Bye.